18 months, and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free Rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke and I'm a consultant dermatologist, a Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of colour dermatology is of particular importance to me. Obviously, I'm a man of colour myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
Morning, sir.
From London, diversity to me means working with those with different ethnic, racial backgrounds.
There you go. Yeah. I'm good. I'm good. Fairly disappointed, but good.
I've been a doctor for the last 5 years, but I've been working with
Not the first to call.
Kings the past couple of months. Diversity to me.
Of all the people, Derek called first.
Hello, I'm Williamson, consultant dermatologist. I've been a dermatologist for more than 20
there you
years.
go. Exactly. You failed on the last day. You had such a good streak.
As you can clearly see,
Yeah, well, get Derek. Get Derek. It's run for one day.
Population we see,
Yeah.
which is South London and even the London
Yes.
population.
At 8:45. Again, changed. She had one more. She was meant to be at 11:45, but then, yeah, and then she's gone now. I mean, we can keep it same as yesterday. You know, we kept the meeting going, and then the guy came in to do a rehearsal. That's actually the guy who's going to do the call today, so he knows the drill. Bye. You know, that was just like, he's here, and then a second I see like he's gone. I was like, cool. Yes, I am. I was like, I was actually allowed to come back today, but I asked Mark a favor because my wife is away in London. Yeah, so like I need to look after the dog. But the thing is, like, if you guys need a help with Derek and you think it's going to be late, when I can always jump in at the evening once the meeting's done and give you a hand. You know, that's not an issue. Really? It looks very busy one because you're taking loads of rooms, but so just a laptop basically. What? so we literally have nothing to do, just kind of sit outside the room and then. I'm here. Trying some presets or. Okay. I can hear a little bit in the background, but like. Okay. Can see that. There you go! Finally can see it. Yeah. Well, that's like, where's this camera? Okay, I see where it is. But that's cool. That's cool, sir. Poking the head for now. Oh, that looks cool though. You can play around. So, how many is it? 3 or 4 cameras you got in there? 3. Yeah. Well, the rear one is just to kind of for Q&As to zoom into people, right? That's the top table. Oh, lecture. There we go. We got them sorted. Yeah, I was actually watching loads of stuff about Remix yesterday while working, so it was pretty cool. Apparently you can do warnings, like reminders kind of idea. Yeah, so apparently like if, let's say you need to record and stream at the same time, but then you by accident you only press stream, then you get a pop-out message saying why you're not recording, but you need to set them. But yeah, the kind of all that stuff, so sounds interesting. Is any? Yeah. Well, as I say, I'm following those guys, their blog on Telegram. So we'll be adding a couple of videos once in a while and then just talking about them. It's like WhatsApp, basically. Just it's more encrypted, so that's the only thing.
The Skin Diversity Subcommittee at the BAD in April
that's the only one.
2020. I am passionate
yes,
about
I will. I will put you there. Go get ready. Go get coffee. Get yourself sorted.
For everyone.
Same for you. I'll speak in a bit.
As the clinical vice president of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao.
I'm a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name's Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of color dermatology is of particular importance to me. Obviously, I'm a man of color myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amwafo, and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
So London, diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. I'm Pew Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consulting dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke, and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of colour dermatology is of particular importance to me. Obviously, I'm a man of colour myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful, and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Royal Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London, diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name is Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Hello, I'm Pugh Banerjee, Consultant Dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population, and that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name's Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke, and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of color dermatology is of particular importance to me. Obviously, I'm a man of color myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London, diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
Good morning, everybody. I'd like to welcome you all to the Professor and Registrar's session, which I will be co-chairing with Professor Richard Warren this morning. I'd like to begin by introducing our first speaker, who is the Thesis Award winner. Dr. Sue Lwin is a dermatology registrar at the St John's Institute of Dermatology and a visiting lecturer at King's College London. Sue joined Professor John McGrath's lab in 2014 as a clinical research fellow to conduct gene and cell therapy clinical trials in recessive dystrophic EB, which subsequently led to her PhD in stem cells and regenerative medicine. Alongside her clinical training, Sue continues to expand her research interests in advanced therapeutics for EB and other skin diseases.
Good morning. Thank you so much for the kind introduction, and it's an absolute honor to receive this award. So, well, also thank you for coming early. So I really very much appreciate your making the effort to attend this session. So I'm very excited to be able to share the thesis work with you, but what I'd like to do in the next 15 minutes is to tell the story, really. It's more about my journey in this gene and cell therapy research. So it all began in 2013 when I attended as a core medical trainee at the International Investigative Dermatology meeting in Edinburgh in 2013. And I saw this man speak about stem cell therapies for EB. At that time, I had no idea what EB was, let alone being able to pronounce it, and also what was stem cell therapy. But that actually captivated my attention. So Professor John McGrath, if you have seen him speak, he's one of the great orators that I've ever met. And as one does, you then go back home and Google what EB was all about. And I stumbled upon this documentary on Channel 4 called The Boy Whose Skin Fell Off. This is Johnny Kennedy, and he was one of our patients at St. John's, and he passed away, and it was about his life as someone living with RDEB, recessive dystrophic EB. And of course, that captured my curiosity, and I wanted to do something different then. And in 2014, serendipitously, there was a clinical research fellow post available in Professor John McGrath's lab, so I then joined the group. So over the ensuing 4 years, I had the opportunity to lead and also participate in, contribute towards 8 cell and gene therapy clinical trials, which I'm very, very grateful for. That's actually helped me equip with the experience and first-hand experience on how to develop novel therapeutics and take it to the bedside, as well as obtaining orphan drug designation, marketing, and so on. What I will focus on actually is the Lenticle F clinical trial. I'll come on to that in more details later on. And indeed, I don't need to introduce this audience specifically about RDEB. It is truly a devastating disease, characterized by, of course, blisters, erosions, chronic wounds, but of course, they eventually develop really aggressive cutaneous squamous cell carcinoma with early death. High disease burden costs the NHS a lot of money, and currently there is no cure. So it's all about dressing, supportive management, and gold standard care that Professor Malario leads at St. John's, of course, provides that support network as well as excellent clinical care for all the patients in RDEB alongside colleagues in Birmingham and also in Edinburgh previously. So prevalence, 3.3 per million population, and incidence of 8.1. And of course, it is a rare disease, but we'll come on to the nature of the pathology in a moment. And it's not just the skin, as you know, that it affects. It affects all the mucous membranes, so in the mouth, esophagus, GI tract, lungs, kidneys, you name it. They have the systemic complications from it. And as I mentioned, it's that aggressive SCC that we always look out for. And children as young as 6 have been diagnosed with aggressive SCCs in the past. Looking at the molecular pathology, zooming into that basement membrane zone, here's the schematic of that. And there are several basement membrane proteins that ensure the adherence of dermal-epidermal junction. But of course, dystrophic EB, as you know, is particularly recessive due to loss of function mutations in COL7A1 gene, leading to either deficiency or absence of type 7 collagen, that is the main constituent of anchoring fibrils in the lamina densa. So when that's defective, then you have that blister in the subbasal lamina densa. But that's what we have known for a long time, but in the recent years, there's emerging evidence implicating innate immune dysfunction, chronic inflammation, microbiome issues leading to fibrosis and, of course, aggressive cutaneous squamous cell carcinoma. So knowing the molecular pathology and also, of course, the golden era of molecular genetics have led to the development of targeted therapies. So, of course, gene therapy is at the very forefront of one of the targeted therapies that people have been researching on within the field of EB. I just want to touch on what is gene therapy because it's not something that we use on a daily basis in clinical practice. So it is either modification or correction of a defective gene with the aim of potential cure. Now, that's a holy grail that we're all still trying to achieve to this day. But very briefly, there are two forms of gene therapy, in vivo and ex vivo. As the name suggests, in vivo, you conduct the gene therapy within the patient directly, often using viral vectors or non-viral vectors. But of course, COVID mRNA vaccine has actually brought gene therapy technologies to the mainstream activities since the pandemic. And the other form is ex vivo gene therapy. That is a lot more involved, where you have to extract and isolate the patient's stem cells in the lab, and then you transduce them, or essentially gene correct them in the lab, and then transplant the gene corrected cells back to the patient, either in the form of a skin graft or injectable cells. But of course, that's much more personalized, but very costly and time-consuming. And the focus of my thesis project was on that lengthy process of ex vivo gene therapy. So around the time when I was starting my PhD thesis, there was only one clinical trial conducted by the Stanford group using patients' keratinocyte gene-corrected cells to be transplanted back as epithelial sheets onto adults with RDEB. And it was, there was encouraging results in terms of wound healing, as you can see, and also the green line depicts the restored type 7 collagen in the middle, correlating to restoration of anchoring fibrils at the basement membrane zone. So the issue with gene-corrected grafts is that, as you can see, they are extremely fragile, and really delighted to see some colleagues from UCL, whom I used to work with, who are gene therapy experts in manufacturing these fragile skin grafts. But of course, that comes with the risk of requiring usually local or general anesthetic, and the risk of graft failure, and of course, infections. And so then we had to think about alternative methods of how can we actually invent something that we can apply clinically in a very sort of feasible manner. So one way to do that is to isolate, instead of keratinocytes, but fibroblasts from the dermis, gene correct them, and that means that we can actually inject them intradermally back into the patient's skin wound sites. And it provides a much more sort of clinically practical system. And that was the aim of my project. So as we call it, the ex vivo autologous fibroblast gene therapy, and at that time when I joined Professor John McGrath's group, the colleagues at UCL have invented this viral vector. It's the iPhone 13 of the viral vectors for gene therapy at the time. It's replication defective, meaning that once the vector has delivered the gene to the patient's cells, it stops replicating, otherwise that could cause malignant transformation and so on. And also very, very clever design of the COL7A1 sequence that they have incorporated in the vector design. And there was preclinical study. Of course, you can see really exciting restoration of type 7 collagen at basement membrane zone alongside the type 7 collagen, alongside the anchoring fiber restoration at the dermal-epidermal junction. So this was the mouse study already done. So my task, no pressure, was to be able to translate this technology and apply it clinically in adults with RDEB. So there I was, provided the little desk on the 9th floor at St. John's, and so within the first year, a good part of the first year, I worked on the regulatory applications, writing protocols, ethic applications, and so on. So that in itself, as much as arduous, it was an arduous task, but I have learned so much, and it gave me that first-hand experience with the regulatory applications and how to conduct an early phase trial of advanced therapeutics. So patients' biopsies were obtained, sent to the Great Ormond Street Gene Therapy Lab, fibroblasts isolated, gene correct them using that latest generation of viral vector, and then the gene-corrected fibroblasts were then injected intradermally back into patients' intact skin because the primary aim is to monitor safety. So my hypothesis was that we can actually provide proof of concept study of this autologous fibroblast gene therapy, and also it is safe and can restore type 7 collagen in adults with RDEB. So this is the trial timeline, follow-up over 12 months, but just to illustrate that the treatment took place on one day, 3 injections on the intact skin, 4 different biopsies at different time points. These were the 4 subjects that we eventually filtered down from 40 that I approached and screened. So very vigorous process that we went through. And you can see that their clinical subtypes really vary, even though they all had RDEB, depending on their mutations. They had either mild, either localized, pre-tibial, inversa, or severe disease. And so they all received the intradermal injection. So you can see it comes in an insulin syringe, tiny amount, 1 million cells in 1 ml, in 0.25 mils, in fact. And so trying to inject that into the skin was challenging, but we managed to do it in the end. So biopsies were obtained from the injected as well as non-injected sites so that we can compare whether there is restoration of collagen 7 in the injected skin. In terms of safety, there were 45 adverse events in those patients, 25 mild, 10 moderate, 10 severe, but they were all related to EB complications rather than the gene therapy. No serious adverse reactions or SUSARs. And in terms of adverse reactions, there were a few, but related to the actual procedure, either biopsy or the intradermal injections, rather than the gene therapy itself. I mentioned about malignancy earlier, and that's why it was important to inject it in the intact site so that there's no influence of the chronic milieu of the wound site, causing SCC, for instance. And we were able to monitor whether there was any pathogenic immune response to either the gene therapy that they receive or the recombinant type 7 collagen 7 that they synthesized after treatment, i.e. there was the risk that they could potentially develop EB acquisitor on top of RDEB. That would have been disastrous, but thankfully there was none of that. And in terms of efficacy, the 50% of the injected skin sites, so that's 6 out of 12 in total in 4 patients, lasted at least, there was an increase in type 7 collagen expression, which lasted for at least 1 year, which was statistically significant. And that's depicted by the white arrows in the injected skin. But what I wanted to know was, so find this type 7 collagen, but how do we know that it's actually coming from the gene therapy and not the endogenous expression by the patients, because we know that they do fluctuate over time. So to do that, we leverage the clever design of the viral vector, which has very unique sequence, different from the wild-type sequence. So using these specially designed primers targeting different parts of COL7A1 gene, I then performed PCR, and absolutely the transgene was detected in the injected skin at month 12. So that was very, very exciting. And this was revolutionary because it was the first time that we were able to demonstrate the clinical correlation of type 7 collagen restoration coming from the gene therapy. However, there were no new mature anchoring fibrils in any of the subjects. So in summary, I was able to demonstrate that ex vivo autologous gene therapy was feasible to be translated in adults with RDEB. It is safe, so the patients are still in clinics, and to date, they are under follow-up for 7 years since treatment. And they can restore type 7 collagen in injected skin, and of course it's directly correlated to the transgene that has been injected and which lasts for at least 1 year in the skin. But what I want to, and of course it was an early phase study, only 4 patients and minimal cell doses, and I believe that if we can actually inject a lot more, we might be able to translate into anchoring fibrils. And it's not designed for assessing efficacy. And so after completing the clinical trial the following year, I was able to deliver the twins simultaneously. So that was the publication of the thesis work alongside my son at the time. But one of the issues that we learned about intradermal injections of fibroblast gene therapy is that patients found that very, very painful, as you can imagine. And the chronic wounds are scarred, and so, at the best of times, it's really very difficult to inject, even the small amounts into the wound sites without causing so much pain. So what I did do, actually, before I managed to complete my thesis was thinking about different modes of delivery. And at that time, there were a few research studies emerging, and I conceived this idea of using a spray-on form of gene therapy. So after a lot of research at that time, managed to get an industry collaborator. So it's a true industry academic collaboration, and I had the privilege and opportunity to lead as a co-PI, funded by Deborah Charity, alongside other funders, to develop a spray-on form of gene therapy as a preclinical development. And of course, looking into opportunities for not just gene therapy, but also cell therapy, as some of you may know, I had the privilege to co-found the Burma Skincare Initiative charity with Professor Chris Griffiths. And of course, as we discuss about other research interests, he mentioned about his interest in looking into advanced therapeutics for psoriasis. And so we reviewed the literature, published the review article about the promise and challenges of cell therapy for psoriasis. So it's a really exciting time. Advanced therapeutics is the next big thing, no doubt about it. But we just need to find ways to conduct clinical trials, as well as to assess safety and efficacy, working closely with the regulators to see whether there is a real benefit using advanced therapeutics for other skin diseases beyond genetic skin disease. And of course, Professor McGrath and Professor Griffiths are working on this alongside our colleagues at KCH, so it's a privilege to be a part of it. And a few personal reflections. It's been an incredible journey, and I'm really very grateful for the opportunity. There were times when I felt that the shoes were so massive for me to fill. Of course, my predecessors made such incredible contributions. And there were times really disorientating as a clinician to go straight into research in advanced therapeutics, but most importantly, learning great science, forming great friendships, and eating a lot of cakes. I think if you know Professor McGrath, you know how much he loves cakes and so on. And on that note, I just want to say sincere thanks, of course, to my PhD supervisors, Professor McGrath and Malario, for giving me the opportunity. And also Dr. Fiona Child, my educational supervisor since day one. She's been for her unwavering support, and also PhD examiners for giving up their time to examine my thesis, and also Professor Griffiths for his mentorship, and all the colleagues, international collaborators, and it's been an absolute privilege, and the funders. And thank you so much for listening and getting up early to attend this session, and I'm very happy to take questions. Thank you.
Thank you very much, Sue, for that interesting insight into the research work that you have been involved with. In the interest of time, we are going to move on, but if anyone has any questions for Sue, please do feel free to approach her to ask. And I would like to present you with your BAD cup before you leave the stage.
Thank you very much, Sue, for a fantastic talk. So moving on, I'd like to introduce our next speaker, Dr. Conor Broderick. And I think Conor is joining us virtually, I understand now. Unfortunately, he's been unable to make it in person. He's going to speak to us about hospitalisation from COVID-19, which is most frequently being observed in patients with AD treated with systemic corticosteroids, particularly when they're used in combination with other immunomodulatory treatment. And this is from the Secure AD Registry. Conor, over to you.
Good morning, everybody. I'm presenting the findings from the Global Secure AD Registry, which evaluated COVID-19 outcomes in patients with atopic dermatitis. And today we will focus on the effects that systemic immunomodulatory therapies may have on COVID-19 outcomes. I'm here today on behalf of our study steering committee, as well as all the clinicians who registered cases in the Secure AD platform. Our research has three main sources of funding, and I've received sponsorship to attend medical conferences. Yesterday, Professor Sinead Langan presented her team's work demonstrating that patients with inflammatory skin diseases are at higher risk of COVID-19 related critical care admissions and death. They found limited evidence for any detrimental effects of standard or targeted immune modifying treatments, with the exception of rituximab and possibly JAK inhibitors. This study drew upon 17 million patients' primary care records and included almost 800 people with immune-mediated skin diseases, namely psoriasis and HS, but did not evaluate atopic dermatitis or patients treated with dupilumab. There are conflicting results regarding the risk of contracting COVID-19 in patients with inflammatory skin diseases, including atopic dermatitis. Some studies report higher risk, while other studies report that atopic dermatitis and atopic diseases in general may in fact be protective against coronavirus infections and may also be associated with lower rates of mechanical ventilation. AD patients' inherent immune alterations notwithstanding, moderate to severe AD is frequently treated with systemic immunomodulatory therapies, including biologics. And we know that these groups of drugs have different mechanisms of action and associated levels of immunosuppression, which may impart varying risks to serious infections. On the other hand, there's also evidence to suggest that some degree of immunomodulation may be beneficial during COVID-19 illnesses. And while huge progress has been made in our understanding of regarding COVID-19, these questions are still highly relevant. Do systemic immunomodulatory treatments influence the outcomes of COVID-19 in patients with atopic dermatitis? And do patients on dupilumab or other novel systemics fare better than those on conventional systemic treatments? I was really looking forward to being in Glasgow, but obviously COVID has put a stop to that. And we're all learning to live with COVID, but that doesn't negate the legitimate concerns facing both patients with eczema and their clinicians, particularly dermatologists who prescribe systemic immunomodulatory treatments for atopic dermatitis. And to help answer this question, we launched the registry called the Secure AD in April 2020. Clinicians enter anonymized patient data. Patients with atopic dermatitis are eligible if they've proven or highly suspected COVID-19. They can be of any age and of any AD severity, and they can be on or not using systemic therapies. The data entry is inputted into the registry after the COVID-19 episodes to allow the disease course to run through. And in addition to demographics and treatment details, we collected data on COVID-19 outcomes and we used hospitalization as the primary outcome in our analysis. This presentation is based on 442 patients registered in the registry from the launch date in April 2020 to October 2021. Our cohort was relatively young, ranging from under 1 to up to 83 years old, with a mean age of 36 years. 70% of COVID cases were confirmed by testing. And while the registry was global, recruiting cases from over 27 countries, the majority of patients were Caucasian. In the registry, 30% of patients were using topical treatments only. Almost 50% of patients were treated with dupilumab, and we had smaller numbers of patients treated with each of the conventional immunosuppressants or the novel immunomodulatory treatments and biologics. 14 patients were treated with more than one systemic immunomodulatory treatment or combined systemic therapy. Overall, serious and severe outcomes were not common in our cohort. 5.9% of patients were hospitalized, and only 8 patients, or 1.8%, were admitted to intensive care, and there was no deaths. When evaluating the crude hospitalization rate by systemic treatment group, there is a significant difference between the groups measured using Fisher's test with a p-value of 0.01. The highest rate of hospitalization are in those on combination systemic treatments, followed by those using systemic corticosteroids as a monotherapy. The difference between topical treatment only and people using dupilumab as a monotherapy was statistically significant with a p-value of less than 0.01. Similarly, mechanical ventilation was most common in patients receiving combination treatments, but the numbers were small, so we focused on hospitalization for the rest of this presentation. So what is the impact of systemic immunomodulated treatment for atopic dermatitis after adjusting for confounding variables? To further evaluate the different rates of hospitalization, we carried out a subgroup analysis of patients on topical treatments or a single systemic treatment, i.e. systemic monotherapy. And amongst 365 patients, we used logistic regression to investigate the association between the systemic treatment they were on and hospitalization. The analysis was adjusted for age, sex, ethnicity, and comorbidities, including asthma, other lung diseases, including COPD, cardiovascular disease, hypertension, diabetes, stroke, and BMI. You can see the adjusted odds ratio and the 95% confidence interval generated from the logistic regression models. Patients treated with topical treatments had a significantly higher odds of hospitalization than those treated with dupilumab, with an adjusted odds ratio of 4.99. Methotrexate and dupilumab had very similar odds of hospitalization. And while cyclosporin and systemic corticosteroids were associated with higher odds of hospitalization than dupilumab, these findings were not statistically significant. From the crude analysis earlier, it is clear that the highest rate of hospitalization is in the combination treatment group, followed by the systemic corticosteroids group. And to investigate this further, we performed another subgroup analysis, limited this time to patients receiving systemic therapies, and thus excluding anyone using only topical treatments. And we stratified this analysis according to whether they received systemic corticosteroids or not. There were 311 patients receiving any systemic immunomodulatory treatment. 7 of these patients were prescribed systemic corticosteroids as monotherapy. 290 were prescribed non-steroidal immunomodulatory treatment, which is either a conventional immunosuppressant, a biologic, or a small molecule inhibitor. And 14, as I mentioned, were on combination treatment. Of this 14, 8 were on combination treatments, including systemic corticosteroids, and 6 received combination treatments which did not include systemic corticosteroids. And as before, the regression analysis is adjusted for age, sex, ethnicity, comorbidities, and BMI. Compared to patients treated with any non-steroidal immunosuppressive systemic treatment, patients receiving combination therapies had a higher odds of hospitalization even after adjusting for confounding variables. The rate of hospitalization is highest in those patients receiving systemic corticosteroids combined with another systemic immunomodulatory treatment with an adjusted odds ratio of 45.75. And in those receiving combination treatments which did not include corticosteroids, the rate of hospitalization was higher with an adjusted odds ratio of 37.57. All studies have limitations, and ours is no exception. As our study was primarily based in a hospital setting and recruited by consultant dermatologists or their teams, our findings should only be applied in this appropriate context. And this is likely to mean that our findings are relevant to patients with moderate to severe atopic dermatitis under the care of a dermatologist. A lot's changed over the last year. We haven't changed the Secure AD platform since the launch, which means that our data set is consistent throughout, but it does mean that we've not collected data on vaccination. We are, however, collecting this data in the Secure AD patient-facing registry, and this analysis is ongoing, but this will allow us to look at the rates of vaccinations and the impact of vaccinations on COVID-19 outcomes in patients with AD. And despite the global recruitment, this study has relatively small numbers compared to the sister registries such as SoProtect or Secure IBD. And in particular, there are small numbers of patients on some of the medications used. This means that our estimates have wide confidence intervals. We also did not have power to adjust for the doses of medications or for country level differences in healthcare provision or COVID-19 rates. In conclusion, the rates of severe COVID-19 in patients with atopic dermatitis on systemic treatments is reassuringly low, and this fits with Professor Langen's work yesterday, which she presented. Dupilumab monotherapy was associated with lower rates of hospitalization than other systemic treatments and lower than topical treatments. Combination systemic treatments, particularly combinations including systemic corticosteroids, were associated with the highest risk of hospitalization from COVID-19. Further data entry and further data analysis may allow us to redefine and stratify further the treatment groups that we've shown today. For example, we didn't have any cases of COVID-19 in patients treated with JAK inhibitors in this data set, but as more cases are registered in the registry, then we should be able to provide risk estimates for this as well. Thank you to our partner organizations who've helped disseminate the study to their members and to the AD patient organizations for their continued support. I'd like to say thank you to the International Scientific Advisory Committee for their support during our project. I'd like to take any questions, and I'll leave this slide on the screen. This is the website, so if anybody does have cases and they're still seeing people with AD, anybody who does register the case in the registry is given the opportunity to be listed as a study co-author in the study group. Thank you.
Any questions for Conor, please? Richard, heading to mic 4.
Thanks for that, Richard Weller, Edinburgh. Look, one of the things that came out of the Secure study was how bad your COVID is depends on treatment response. So, for instance, corticosteroids increase mortality from COVID in those with mild COVID, but reduce mortality in those with severe COVID. So, as I understand it, you kind of stratified by severity of eczema. What about stratifying by severity of COVID? Do you know if these... It's a difficult one to assess. Have you given that some thought?
Yeah, thank you. Yeah, the recovery trial was obviously, it completely changed the landscape of treatment. All these people would have been on systemic steroids before they had COVID. So it was for treatment for AD rather than treatment of COVID. In terms of the severity of COVID, which I think was the question, we've used the hospitalization as the marker of severe COVID in this cohort because intensive care admission and ventilation rates were so low. So we've used the severity of COVID as the outcome rather than as a factor to control for in the study.
Okay, so Conor, I'm going to stop there. Thank you very much for joining us this morning. I hope everything is well with you. And unfortunately, we can't present your mug to you, but we will ensure you get it in due course. So don't worry about that. So well done, Conor. Thank you very much.
Thank you.
So I'm delighted to introduce the first plenary of the morning. So Professor Tony Bewley is our next speaker. So Tony, I'm sure, is well known to all of you, and of course, most recently so because of his role as an officer for the BAD. But this morning, Tony's going to be talking about psychodermatology, and I think he's been a pioneer with this over the last 20 years, leading in both the UK and on the European front, and in terms of editorship with multiple journals as well. And Tony, you've got a big clinical academic portfolio, I know. So looking forward to your talk, Psychodermatology Lessons from the Last 20 Years. Thank you.
Brilliant, thank you, Richard. Yeah, Tony Bewley, I'm a dermatologist over in Barts Health and also honorary professor at QMUL. Now, just over about 20 years ago, when I was over at Barts Health, we had a psychiatrist who joined us, and from that moment, we set up the psychodermatology clinic over there. And this talk really is aimed about trying to learn the lessons that I've gained over that past 20 years. So these are my potential conflicts of interest. Psychocutaneous medicine, then, two sides of the same coin. It is either primary psychiatric disease, presenting to us as dermatology healthcare professionals, such as delusional infestation, body dysmorphic disorder, and so on. Or it is primary dermatological disease in which there is large psychosocial comorbidity, so acne, psoriasis, atopic eczema, where there is disorders of image, anxiety, and or depression, and so on. Now, lesson number one, patients with psychodermatological disease are common and may have surprisingly severe disease. So these are two patients, and if you need any lessons about how much emotional pain hurts more than physical pain, then you can join a psychodermatology clinic. The lady on the left gradually pulled apart her scalp, and the lady on the right gradually picked a hole or a fistula between her buccal mucosa and her skin. Now, these patients are not that rare, and they tend to go from specialty to specialty without being engaged until somebody organizes a multidisciplinary team meeting, gets them better, and then that can work. So more and more we are generating multidisciplinary team meetings with plastic surgeons, CMHT, in other words, the psychiatrists, or other people, primary care, for example, in looking after these patients. 2020, we published the All-Party Parliamentary Group on Skin report, and then subsequently talked about the Psychodermatology PSP. We know that about 98, a whopping 98% of our patients who have skin disease will have psychosocial comorbidities, and about 5% of patients with skin disease consider and or act on suicidal ideation. And sadly, only 18% of those patients realize that they can be signposted or directed to psychological support, whether that be talk therapies or pharmacological interventions. So the report, the APPGS report, made it very clear that we need to have at least regional, comprehensive, what do I mean by comprehensive? I mean psychodermatology clinics that look after primary psychiatric patients, because these patients do not want to engage with psychiatrists. They do want to engage with us as dermatology healthcare professionals. So at least regional, comprehensive psychodermatology services, not just primary psychiatric disease, but also primary dermatological disease in which there is large psychosocial comorbidities. There have been 3 surveys about UK provision of psychodermatology services. The first one was back in 2003 with Chris Bridget from the Westminster Hospital, and 2 of ours subsequently. This is the 2019, and it is slowly getting better, but it still is very poor. For example, there is no psychodermatology service in Wales, and there isn't a lot in Scotland, though Dundee does have a psychodermatology service. And yet we know from lots of research that managing patients in combined multidisciplinary psychodermatology clinics is actually very cost effective. So we can prove that if you look after patients in multidisciplinary services, you don't just get them better more quickly, but you get them better more comprehensively, and it is more cost effective. And happily, the GERFT report from Nick Lavelle has made that very clear as well. So the recommendation is to improve access to dermatology specialties, including hair, nail disease, female and male genital skin disease, and psychodermatology. So the evidence for the need and benefit of at least regional comprehensive psychodermatology clinics nationally and actually globally is very compelling. What do we name the subspecialty, and how do we communicate with other members of the wider medical team? Well, the European Society for Dermatology and Psychiatry, I happen to be the president of this organisation at the moment, is kind of wrangling about what we call ourselves. There is some move towards calling it the European Society for Dermatology and Psychosomatics, because psychiatry seems to be too pathological and is non-inclusive. And yet the psychologists, the people we're trying to include, have reacted against the term psychosomatics. DSM-5, the American Psychiatric Association, also struggles with a comprehensive term. You could call it skin and mind, you could call it psychocutaneous medicine, but it's difficult to come up with a term that is kind of comprehensively acceptable. Certainly in our clinic, when we called it the multidisciplinary team clinic, patients flooded into the department, and our waiting list is huge. It's well over 10 months. So if you set up a psychodermatology clinic, you will have patients frequently, and there will be plenty of them. We changed it, care of our managers, to the psychodermatology clinic, and loads of patients DNA'd. So if you call it the psychodermatology clinic, patients may not find that very embracing. So we still call it the Bewley Clinic or the Multidisciplinary Team Clinic, and that seems to work. Remembering that psychodermatology is a multidisciplinary team service, and we very much rely on people like our dermatology nurses and our psychologists and psychiatry support. And making sure that you maintain a psychodermatology service is really important. So it can depend on local expertise, who's around, who can fill the clinic. So other lessons: don't call the clinic psychodermatology clinic. Patients don't embrace that, whereas they will embrace a holistic clinic or a multidisciplinary team clinic. For the time being, the specialty is going to remain psychodermatology, and building a psychodermatology team does depend on local expertise. What we did was we made sure before block contracts were around, and when block contracts end, which they are supposed to end, we've made sure that we do apply bigger tariffs, because you will see fewer patients, and it is important to fund the clinic. And be patient. We're very clear to our patients. So I sit with a psychiatrist, and I introduce myself as Tony Bewley. I'm the dermatologist, and Ruth Taylor or E.S. Asselman says, "Oh, I'm Ruth Taylor, and I'm the psychiatrist." And we automatically then say, we're here because skin disease often has psychosocial problems, and we want to embrace the patient rather than the disease. Only twice in this 20 years has any patient said, dump the shrink, get rid of the shrink. Twice. Both of those patients were forensic patients. In other words, they had some kind of criminal record and so on. And sometimes patients can be quite divisive, and they can try and say, oh, the psychiatrist is not a good doctor and the dermatologist is the good doctor. So you have to be very mindful of that. But do introduce who is there in the room at the time. And also, when you're replying to GPs or to patients these days, describe the symptoms or what you can see rather than calling it delusional infestation. Time after time after time, I've had patients come to me and they've been to see loads of other doctors, and somebody has called it delusional infestation, and the patient has got very angry with the GP, with the dermatologist, and also they then arrive in our clinic loaded with anti-dermatologist antibodies. So try and call it symptoms rather than the label. If you work in psychodermatology, you will get complaints, and this was rather an abusive complaint about my care. Sometimes they can be quite unpleasant, and this particular chap, and I'm not breaching confidentiality by showing his photo because it's all over YouTube, and he went around the UK and named various people, and on the left you can see one of my colleagues who has also on the internet put out information about this particular patient. So some of them can be unpleasant. There are solutions to that, though. First of all, it's very important to be really clear about your work-life boundaries. So some of the patients will come along and they will flatter you, and they will tell you you are the only doctor who ever listens to them, and they can't go through life without seeing you. And it's very easy to get caught up in a dependency about that, and it's very foolish to get caught up in a dependency about that. So make sure you maintain your boundaries. Work is work, and you do not take calls outside of work, and you do not encourage patients to get into an email dialogue on a day-to-day or any other basis. We make sure that we keep a database of our patients. We make sure that we have extra nice biscuits during the psychodermatology clinics. We do have good psychiatry supervision. We definitely have a multidisciplinary approach, and we definitely have reflective practice. And this is something we as dermatologists need to get better at, making sure that we can reflect on how we can do things differently and or better. We have a monthly national MDT meeting, and anybody is welcome to join us. Dr. Alia Ahmed coordinates this. The bit on the right is actually the ESDAP multidisciplinary team meeting, because I couldn't get we haven't got a photo of the UK national one yet. But people are beginning to get to grips with this and will come along with their patients and their difficult stories, and we will be able to offer you clear supervision. Training is important, so ESDAP has a training biennial conference. The next one is next year in the Netherlands, so do join ESDAP, do come to the psychodermatology training. But here in the UK, we have an annual Psychodermatology UK training school, and it's filled up every year. And what's interesting is that it tends to be the trainees, but consultants are also very welcome to join this Psychodermatology UK BAD training school. And of course, we have the PUK annual meeting every year too. So do let us know if you want to come to the training school. So if you get complaints, be clear about your boundaries. Do not generate dependencies. Check the patient's capacity to complain. Make sure if you're dealing with a complaint, you deal with it succinctly. Do not go into great big long essays about complaints. And I worry that the more you go the extra mile with psychodermatology patients, the more likely they are to complain. Now I'm going to talk a little bit about delusional infestation, which has various preceding names. It is a monosymptomatic hypochondriacal psychosis. In other words, these patients are deluded, but they have a single symptom in terms of their delusional belief. We call it infestation because these patients these days tend not to talk about parasites or worms. They can talk about a range of different things, including fibers and nanoprobes. So we talk about a comprehensive infestation. Now, time after time after time, patients who've been to see other dermatologists come to me and they say, the doctor didn't even look at my skin. They didn't, because you make a diagnosis very swiftly in your clinics, and it's very tempting to think, oh, well, I can deal with this very quickly. There's no point in looking at the skin. There aren't going to be any worms or parasites. But it is really important that you do look at the skin, because that will help the patient to feel engaged, and it will embrace your capacity to engage the patient. Do also take their specimen signs seriously. So whatever they bring, it might feel tedious to you, but do always embrace whatever they're bringing, take it seriously, look at it, and if necessary, send it off to your laboratory. Now, as you know, delusional infestation is divided up into primary, in other words, no underlying cause, or secondary. And the commonest cause of secondary, and the majority of our patients, about a third of our patients, have a recreational drug habit. So we routinely check for recreational drugs, or we ask about recreational drugs in our patients. And actually, this is shifting into my general practice. So in my medical dermatology clinic, I routinely ask our psoriasis patients or our atopic dermatitis patients, are you doing any recreational drugs? I routinely ask this. We know, for example, with psoriasis patients that they can access not particularly helpful coping strategies like alcohol, and we are aware, and we've done a pilot study on this, that some of our psoriatics, more commonly than the background population, are accessing recreational drugs, and that might matter. If they are accessing recreational drugs, then whatever their narrative is, I don't react to their narrative. So sometimes we'll say to a patient, are you doing recreational drugs? Definitely not, doctor. You test their urine and it comes back with cannabis or cocaine or whatever it might be, and you'll say to the patient, you said you weren't doing recreational drugs, but actually, you know what, we found a bit of cannabis in your urine. And their narratives range from, well, I was at a party and somebody had the window open and I'm sure next door was smoking a spliff and I inhaled. Whatever their narrative is, or it could be, I went to the local Ayurvedic clinic and I'm sure that they've got cocaine in their pasties. So whatever their narrative is, you know, you just think fine and you don't react to that, but you are clear that recreational drugs probably will contribute to their disease. Now, this was important work which was done via the Europeans, by myself, together with various European colleagues. And what we found was that the longer you leave patients with, in this case, delusional infestation, untreated, the worse the prognosis for any of them, the less likely any treatment that you're going to offer them is going to work. And this is true for the schizophrenic population. In other words, the longer you leave untreated schizophrenics without an antipsychotic treatment, the less likely any antipsychotic treatment is going to work. Any antipsychotic treatment is going to work. So it's true also with delusional infestation. If you don't treat them, the longer you don't treat them, the less likely any of the drugs we're going to try and engage them with is going to work. So the message of this is try and engage them with an antipsychotic early, straight away, first consultation. Try and embrace them and get them onto an antipsychotic, because the longer you leave them untreated, the less likely it is that anything is going to work. So consider starting, and this is true for all psychodermatology conditions, consider starting medication or talk treatment for the psychiatric, psychosocial comorbidities as soon as possible, but also treat the skin and the psychological condition simultaneously. So do treat the skin at the same time, because that's going to be important. Now, just recently we have published the first global psychodermatology guidelines, and this is available through the BJD. So we have published the guidelines about the management of patients with delusional infestation. The point is, treat their skin, but treat them with an antipsychotic straight away. And there are useful, helpful advice about how to engage patients with delusional infestation too. So British dermatology, British psychodermatology is probably leading globally about the management of psychodermatology conditions. Remember, with patients who have delusional infestation, there may be risks for vulnerable adults, and frankly, there may be risks in terms of child protection too. So, for example, I had a family who came to me. Mum was the index patient, and she presented with 4 children, and she was convinced that all 4 kids had an infestation, and she wanted us to treat the kids with something that was going to get rid of their infestation, whereas actually the patient was the parent rather than the children. So be mindful about those risks. Making sure that you engage the patient is really crucial, and do not, in kind of counter-distinction to the previous complaint, do not underestimate the power of listening. So this is one of the emails that we received to say thank you very much, and it is really powerful to listen to how much just listening to patients can be so helpful. So further lessons are: be mindful about vulnerable adults and child protection risks. Engagement is crucial, so engaging the patient is what really matters, and never underestimate the power of listening. Just zipping and listening can be really powerful for our patients. Now, I don't want you to think that the only thing that we do in the psychodermatology service is look after patients with delusional infestation, because that most certainly, absolutely is not the case. So, for example, we do look after patients with BDD, and this matters particularly with the current debate about isotretinoin in acne patients. What we have found is that acne patients, for example, have a really high risk, especially in the adolescent population, of body dysmorphic disorder, and that matters because body dysmorphic disorder is very much associated with suicidal ideation and other psychosocial comorbidities. So we do work across Europe with other conditions as well, and we are describing newer psychodermatological conditions. So we all know about trigeminal trophic syndrome, but we're now talking about cervical trophic syndrome and also atypical variants of trigeminal trophic syndrome. Trigeminal trophic syndrome often misdiagnosed as dermatitis artifactum. And we're also aware, and we're going back to the very first slide, that psychogenic self-mutilation, we do see a lot of these patients, and they tend to just go between lots of different groups of physicians or surgeons, including plastic surgeons. And what really helps is if you engage these patients, set up a multidisciplinary team, then you can actually get them better fairly comprehensively. There are some books about psychodermatology, and this is my team. A few years ago, we won the BMJ Team of the Year, Dermatology Team of the Year, and it is very much a team. Brilliant. Thank you very much for your attention.
Thank you, Tony. Any questions from the floor? I wondered, Tony, how long you give each patient an appointment?
Yeah, it's a good question. People always say this, and it's surprisingly not as long as you think. So the BAD and Psychodermatology UK back in 2012 established recommendations for what a psychodermatology clinic looks like, and it should have 45 minutes for a new patient and about 20 minutes for a follow-up. I dream of that kind of time span. We don't get anything like that, but some patients do take an hour, and we just have to invest that time, and some people take a lot shorter than that. Certainly the follow-ups, and if you can engage, for example, the dermatitis, the delusional infestation patients, if you can engage them with antipsychotics, then the follow-ups are usually quite straightforward. One thing I would say as well, actually, with the DI patients, one of the ways to check that the patient, objectively check that the patient is taking their antipsychotic, is to check their prolactin level, and we have published that as well. So if you check their prolactin level, you can objectively make sure that they are actually taking the medication, but even clinically you can usually tell.
Thanks. We'll go to Claire. Nick, we may not, in the interest of time, have a second question. Sorry, Claire.
Just to thank you, first of all, for all you do, and we just so value your service and support and guidance over the years, so really, really thank you. It's a major lifetime achievement. My question was about drug testing, and I wondered whether you don't always consent specifically for that when you take...
Yeah, so it's a really good question. If you have a patient and you're going to check for recreational drugs, we routinely say to the patient, are you doing recreational drugs? Yes, no. And it's a very routine question. Do you drink alcohol? Yes, no. Are you smoking? Yes, no. If you're smoking, what are you smoking? And do you do recreational drugs? And it's routine, and I've not yet had any patients say it's none of your business, doctor. And if they do, fine, I respect that. If they say they are doing, or even if they say they're not doing, we will routinely say to them, are you okay if we do a drug toxicology screen? And again, they will say yes, no to that, and that verbal consent is enough. And if they say no, we don't do it. If they say yes, we do. And then we do the toxicology screen, and we go from there. But a verbal consent is absolutely fine for that.
Nick, very quick, please.
Yeah, very quick. Similar lines in a way. Thanks very much for the talk. So the patients who are on recreational drugs, do you still give antipsychotics?
Yes. So it is common in drug and alcohol rehabilitation. Drug and alcohol, what do you think the chances of patients who are on recreational drugs becoming clean? Most people think it's quite high, but actually it's 5%. 5%, so 95% of patients who go through, and this is the patients who go through the rehabilitation services, not the huge number of patients who don't even engage with rehab services. 5% of patients are clean. So 95% of the cases, it's about harm reduction, whether that be harm reduction in terms of blood-borne viruses or about other comorbidities, but it's also harm reduction in terms of psychosis. And so it is common for patients who are on particularly things like amphetamines or cocaine, it is common for them to be on antipsychotics as well. or for that matter, antidepressants or whatever it might be. In fact, some of them are routinely on street-acquired benzodiazepines. So it is okay, perfectly okay, to prescribe and to use antipsychotics at the same time as using their drugs, whilst saying to them, please do engage with a drug and alcohol rehabilitation service, and giving them a really clear message. There is no point in mixed messages here. I say to the patient, you need to stop whatever it is now, forever, and never go back onto them. So, and it's, you know, Chris and other people from Manchester have engaged in the whole motivational interviewing, which is now applied to psoriasis, comes from drug and alcohol rehabilitation services. So getting the patient to set their own goal and to try and establish some way of deconstructing their habit is really important. But in the meantime, it's not a problem to prescribe whatever you need to do. If anybody is worrying about starting patients or monitoring patients on antipsychotics, join our MDT and we will supervise you, support you, and you'll get a written reply to your comment about your MDT. You can put that in the electronic patient records or in the patient notes, and we will together be taking responsibility for those patients.
Thank you, Tony. That's great. So thank you very much. Just to, Tony, to give you your mug, and also just be aware you might have a certain Boris Johnson in your clinic next week, as I understand he has resigned.
Oh, Lordy.
The next registrar paper is presented by Dr. Ali Al-Janabi, who is a registrar at the Northern Care Alliance NHS Foundation Trust in Manchester, and will be presenting a nested case control study on risk factors for paradoxical eczema in psoriasis patients on biologics.
Thank you. Hello everyone, I'm a PhD student in dermatology registrar in Manchester, and I'll be presenting work from my PhD where I'm aiming to look at the mechanisms of paradoxical eczema which can occur as an adverse event to biologic therapy, and it's something you may well have seen in your clinical practice. And this work specifically looks at the clinical risk factors. Here are my disclosures. So psoriasis and atopic eczema are clinically distinct diseases, both morphologically and in terms of their immune mechanisms. Psoriasis is a disorder of Th17-mediated immunity, with IL-17 and IL-23 being key cytokines in the pathogenesis, whereas atopic eczema, although it's heterogeneous, is a disorder largely of Th2-mediated immunity, driven by cytokines such as IL-4 and 13. Although they're both common, they don't occur together as often as you might expect, and there is evidence that these conditions antagonize each other. So genetic studies have shown that there are risk variants that increase your risk of psoriasis, but at the same time can reduce your risk of atopic eczema. And also in conditions looking at lesional skin in patients that do have both diseases, the skin phenotype typically polarizes to one or the other in a particular site. Furthermore, in the asthma literature, there is evidence that these two arms of the immunity, Th17 and Th2, reciprocally inhibit each other. So Th2 cytokines can actually downregulate the production of Th17 cytokines. It's therefore intriguing that some patients with psoriasis can develop atopic eczema after exposure to a biologic therapy. We think that patients that develop this have a genetic predisposition to both, but for one reason or another, they have psoriasis when we see them. And we propose that there's an inhibition between these pathways. When we then introduce a biologic therapy, the psoriasis improves, typically, but the atopic eczema then manifests. And what we usually find is after withdrawing therapy in these patients, the atopic eczema gradually resolves and then the psoriasis recurs. And we like to consider this as a sort of tug of war between these two phenotypes and arms of the immunity. And we're now starting to see the inverse happening with targeted therapies for atopic eczema, with some patients developing inflammatory arthropathies or even psoriasis. To highlight how this is such a problem for our patients, I'll just focus on one of our cases. And this gentleman had a history of atopic conditions as a child, which resolved in his early teens, and then developed psoriasis at the age of 20. He went through traditional systemic therapies with great difficulty, was eventually started on a TNF-alpha inhibitor, and shortly afterwards developed an atopic eczema phenotype, or paradoxical eczema. Eventually, we switched treatments to an anti-IL-17, which is at the time of this photograph, and we can see these well-demarcated plaques of psoriasis on his trunk, and more poorly defined patches on his trunk, on his shoulders, and also in his antecubital fossa, which represent atopic or paradoxical eczema. Histology showed spongiosis, which supported the diagnosis, as well as psoriasiform hyperplasia. And this is a major issue, so it's not only interesting, but this gentleman cycled through every single biologic class, repeatedly developing flares of atopic eczema. This caused challenges in managing his psoriasis, and there was a direct impact on his quality of life. In our experience in the Manchester Psoriasis Service, this affects around 2% of our patients at some point in their journey. In 42%, we stop or switch treatments, and even switching treatments doesn't guarantee that this will not recur. So this is not a class-specific or drug-specific adverse event, and we've had cases on multiple biologic classes, sometimes in the same patient. Current evidence is mostly limited, so I undertook a literature search very early in my PhD. It's mostly limited to case reports. There have been some small studies looking at lesional skin, which have shown either a predominantly Th2 inflammatory profile or a mixed inflammatory profile. And quite recently, there was an ixekizumab safety analysis looking at trial data, which found an association with a history of atopic eczema and eczematous reactions to ixekizumab. So the aims of the study I'm presenting today are to describe the clinical features in a large cohort, and to look at whether atopic history and other clinical factors are associated with this phenomenon. So this study utilized bad beer, which is the biggest pharmacovigilance register globally, and we undertook a data search for March 2021 and looked retrospectively at adverse event data for patients with plaque psoriasis exposed to biologics, cases being patients that developed a paradoxical eczema event during biologic exposure, and controls being everybody else. And I'll present data on descriptive statistics and some associations which we identified using logistic regression after controlling for some confounders. So just to summarize the study population, I'll draw your attention to 3 or 4 key statistics. So relative to controls, patients with an atopic history were more common in cases, as were female patients, and patients of a slightly higher median age. The ethnicity mix was similar between cases and controls, with approximately 90% being of white ethnicity and smaller numbers of other ethnicities. Now looking at biologic exposures, so the left 2 columns show the biologics that cause the paradoxical eczema events, and we can see that 70% of events occurred on either adalimumab or ustekinumab, which broadly represents prescribing practices within bad beer. We did have a reasonable number of cases on IL-17 inhibitors and a small number of cases on the newer anti-IL-23s. In terms of time to onset, we can see the distribution is skewed towards the start of biologic therapy. The median time to onset is 260 days. Although, interestingly, there were cases developing even after 2, 3, in some cases 7 or 8 years after biologic initiation. So there can be quite a significant latent period. And there was no significant differences in time to onset between the biologic classes. The distribution of eczema, much like atopic eczema, was highly variable, so it affected the face commonly, flexures, limbs, trunk, so really any skin site could be affected. And the most commonly used treatments in the bad beer registry were topical therapies. 6% of patients had systemic therapy such as cyclosporin, and in 12% there was a change in biologic therapy, whether it was paused, switched, or stopped altogether. 2% of participants had phototherapy, and 2% were admitted to hospital as a direct result of the paradoxical eczema. Now looking at some associations, so this plot shows the odds ratios and 95% confidence intervals, and we can see that there's quite a significant association with a prior history of atopic eczema, so that's at baseline registration in bad beer, with an odds ratio of over 20, but quite broad confidence intervals. There's a similar story for hay fever or having one or more atopic condition, but when we look at asthma specifically, there was no association with this phenomenon. And looking at other covariates, there's an association with increasing age, female sex, and a history of psoriatic arthritis. We didn't find an association with ethnicity, but as mentioned earlier, we did have very small numbers of non-white participants. So in terms of biologic classes, so anti-TNFs were used as the reference category, and we found an increased odds on anti-IL-17s, but that's non-significant, and also ustekinumab. There's a lower odds on the anti-IL-23p19s, but due to the small number of cases, the very broad confidence intervals is also non-significant. When we look at each biologic drug individually, the only one that reached significance was etanercept, having a lower odds of paradoxical eczema. The effect size for ustekinumab was similar, although in this analysis it was non-significant when compared to adalimumab. So just divulging slightly on potential mechanisms. So why could ustekinumab be associated? So this is a case control study, so it's not really looking for causation. But if this was a causative phenomenon, then one hypothesis is that there are obviously naive T cells in the skin. These differentiate into a variety of subsets based on various stimuli and the cytokine microenvironment. And ustekinumab targets two cytokines, IL-12, which is important in Th1 differentiation, and IL-23, which is important in Th17 cell differentiation. So it's possible that by blocking two T cell subtypes from developing, this increases the pool of naive T cells that could develop into Th2 cells in the right circumstances. But this is, of course, just a theory. So in summary, we found an association between paradoxical eczema and ACP, increasing age, female sex, psoriatic arthritis, and exposure to ustekinumab, and where there was a lower odds on etanercept exposure. So for the remainder of my PhD, I'm looking at genetic risk and also hoping to look at their disease profiles in blood and skin over time. I'd like to thank the participants of BADBIR, my supervisory team, MRC, who are funding my fellowship, and the BADBIR team.
Thank you very much, Ali. We have time for one question.
Richard Weller, Edinburgh. Thanks. I really enjoyed that fascinating talk. Look, so have you compared your various biologics against anti-TNFs? Have you compared against the old-fashioned systemic agents like methotrexate or cyclosporin, which are non-selective and treat both eczema and psoriasis, and against which presumably should have a reduced risk against your TNF as a one of developing eczema?
So no, we haven't done that, and that's a good point. I think if we were to do that, I would expect that we'd see that all biologics have an increased odds of causing this phenomenon relative to systemic agents. But the question that we tried to address was, is there a difference between the biologic classes? But that is a good question and something that we should consider doing.
Thank you, Ali. Before you leave the stage, we'd just like to present you with your BAD cup. Our next registrar paper is presented by Christopher Felix Brewer, who is a specialist registrar at Cambridge University NHS Trust, and will be presenting Galia versus Periosteum, the impact of excision depth on outcomes for cutaneous squamous cell carcinoma of the scalp.
Good morning, everyone. My name is Felix Brewer. I'm a plastic surgery registrar in Cambridge. And I just want to spend the next 10 minutes talking about a project that we did looking at whether the excision depth of squamous cell carcinoma on the scalp impacts the outcomes, in particular occurrence rates and the margin involvement, deep margin involvement on histopathology. So I'll run through the outline of our project, how we did it, and then some of the conclusions we've got and the recommendations that we sort of made from the results of this work. So just a little bit of background about cutaneous squamous cell carcinoma. So it's the second commonest type of skin cancer, as I'm sure you all know. and it has a relatively low disease-specific mortality, but recurrence and metastasis rate around about 5% each. Up to 54%, the majority of these cancers occur in the head and neck region. And this can confer a significant aesthetic and functional morbidity because these tumours require quite a wide excision and subsequent reconstruction. And surgery is currently the most common treatment modality for SCCs. So a little bit of background on the anatomy of the scalp. So there are 5 soft tissue layers in the scalp. So you've got the skin, connective tissue, your aponeurotic layer, which is between the frontalis and occipitalis muscle, in other words, what we call the galea, loose areolar tissue, and the periosteum on top of the bone. And typically, excision of skin cancers on the scalp is either performed to the galea or the periosteum, as they are macroscopically identifiable layers during the excision. Furthermore, both these soft tissue layers will accept a skin graft, full thickness or a split thickness skin graft, which is typically the most common type of reconstruction for these lesions. However, there's no consensus currently amongst the guidelines as to what excision depth should be performed. So the BAD guidelines state that the excision should include the galea when excising cutaneous SCCs, as do the Scottish guidelines, but internationally, the guidelines do not state what depth it should be excised to, and some guidelines say it should only be excised to galea and not further. So that was a real question we wanted to answer. Does it make a difference if you excise cutaneous squamous carcinomas to galea versus periosteum? And the 2 ways we want to answer that question is, first of all, does it impact the deep margin status? And what do I mean by that? Well, when the samples are analysed by our histopathology colleagues, is there a difference between the number of samples that have a close or involved margin on the deep side of the specimen for those lesions excised to galea versus periosteum? Secondary outcomes of our study were, are the recurrence rates difference between these 2 patient groups, and what is the overall tumour demographics and patient demographics between these 2 groups? So this was a retrospective study which we performed in 2 hospitals in the east of England. And our inclusion criteria was patients over the age of 18 with cutaneous SCC excised during a 5-year period. We excluded patients which had SCC which had invaded to bone, as obviously the excision depth would need to be down to and beyond that layer. Excluded patients where there was inadequate documentation as to the histopathology or the layer in which the SCC was excised to. Children, and any patients who had SCC from the frontal or occipital areas of the scalp where there is muscle as opposed to the galea aponeurotica. 410 lesions were eligible for analysis, and we excluded 108 of these based on the exclusion criteria, which I just mentioned, leaving 302 lesions included in the study, 80 of which were excised to galea and 222 excised to periosteum. And these were lesions excised by both dermatology, plastic surgery, and also primary care teams. So the first thing we looked at was the patient demographics and the tumour demographics between the 2 cohorts. And there was no significant difference between these factors. So what our study showed really is that it didn't seem to be a bias based on what the size of the lesion was when it came into presentation as to what the depth it would be excised to. So then we looked at the deep margin involvement, both close margins, that is where there was tumour within 1 millimetre of the deep margin, and also specimens where there was involved margins. And when we combined these 2 factors as a close or involved margins, we found that a significantly greater proportion of patients who had lesions excised to galea had involved or close deep margins compared to periosteum. We then looked at tumour recurrence rates, and again we found that local recurrence was higher in the cohort which had lesions excised to galea versus periosteum. We also performed a regression analysis adjusting for potential confounding factors such as the tumour stage, differentiation status, perineural or perivascular invasion, and we found that there was an odds ratio of 2.74 times more likely to get local recurrence if the lesion was excised to galea versus periosteum. And our mean time to local recurrence was 17.7 months. It was a little bit longer than the typical local recurrence times for cutaneous squamous cell carcinomas. So what are the main conclusions of our study? Well, first of all, as far as we can see, this is one of the first studies that's actually looked directly at the local recurrence rates and margin involvement for SCCs excised at different depths on the scalp. And we've shown that through this analysis that lesions excised to galea were more likely to have involved or close deep margins and were more likely to have local recurrence. Limitations of our study, well, first of all, there's a relatively low number of recurrence. It's about 10-11% in this cohort, so we had a relatively low number of patients, and of course, the data could be improved by having a larger sample size. There's potential confounding, which we were unable to control for in this study, such as patient comorbidities, history of previous SCC, and the original tumour size. And there is, of course, a possibility that some patients were lost in this study because they went to other units for the follow-up, or they weren't followed up if they did have a local recurrence of the SCC. So there are two things that we really wanted to draw out from the study, and two sort of recommendations. First of all is we think that cutaneous SCC of the scalp should always be excised to the deeper depth, down to periosteum, to minimize the risk of recurrence and therefore further surgery or radiotherapy in future. And secondly, we think that cutaneous SCC of the scalp should possibly be considered to be upgraded with regards to its risk status in lieu of the fact that the recurrence rate in our study was around about 10 to 11%, which is higher than the average, it's about 5%, and the interval to recurrence was 17 months, which is again higher than the average for all site SCCs. And currently, the guidelines that dictate that the tumour site for lesions on the ear and lip should be high risk, and these lesions get followed up for a slightly longer period in secondary care. And based on this data, we think that there's the suggestion that possibly the scalp should be included in a higher risk category based on anatomical region. Thank you very much. Happy to answer any questions.
Thank you, Felix. We do have a couple of minutes if there are any questions.
Thank you for the lovely presentation. I can see that you had also the breast lobe thickness. Have you done any statistical analysis to see the association between tumor depth and versus galea or periosteum?
So we looked at the TMM status on the histopathological specimens and compared them between the two groups. We didn't look specifically at the depth, that we used the TMM status as our basis for the degree of invasion for the SCC.
Yeah. Can I suggest that it would be a good idea if you could do that, because it's just like melanoma. With the melanoma, according to the breast lobe thickness, we can take 1, 2, or 3 centimeters. I mean, this study with these numbers, you could also have something conclusion and useful for us.
Certainly, yeah, we do that.
Hi, yeah, thank you very much for your presentation. It's very good. I just wondered, what did you do with those ones with involved margins, particularly with the galea? Because then how did they sort of go into your recurrence rates?
As in, what did we do sort of clinically with those patients?
Well, clinically, and also how did you then kind of take, if you did another treatment, radiotherapy, surgery, are you still including those in your recurrent rates, or did you take them out?
So once they've had their first recurrence, we take them out. We took them out of the study. So we only looked at the one recurrence. And in terms of the clinical management, then that was, of course, patient-specific. Some patients, it was radiotherapy, particularly if it had been excised to periosteum, and some patients it would be a further deeper excision if that was viable. But often, if there was a recurrence, often that recurrence had actually gone into the bone by the time that we saw these patients again. So a deeper excision, including periosteum, wouldn't actually make, wouldn't clear the tumour.
I suppose what I was saying is if they've got involved margins and you've done the surgery at that point rather than before they've got a recurrence, did they do better overall?
Oh, I see. So yes. So if we had patients who had an involved margin to begin with, yes. Typically, we would go on to do further excision. If it was down to galea, yes, down to periosteum. And those patients were excluded then from the group, yes.
We have time for one more question, and any further questions can be asked in the break, which will follow this session. So, question at the front here, please.
I'd like to congratulate you on measuring the levels, and that's one of the things we want clinicians to do at the time of surgery, is to record the anatomical depth when they remove a squamous cell carcinoma. I wasn't sure if you measured the diameter of the tumours on the scalp, because that's obviously an important risk factor there.
No, we didn't, and that's partly because that data wasn't recorded. And the reason it's often not recorded is because there's often quite a large keratotic scab over the top of the SCCs, which weren't necessarily always fully removed before assessing the size of the lesion. So unfortunately, that data wasn't there.
So I think that is an important factor, and probably why there's a high risk in some of these patients with very large diameter scalp tumours.
Absolutely, yeah, thank you.
Thank you very much, Felix. I'd like to present you with your BAD cup before you leave the stage. We will be pausing for a break now, and the second part of this session will resume at 10:45.
Okay, so we will get this session going on time. Nice to see you all back. I'm Richard Warren, dermatologist in Manchester, and Ikra is my co-chair, who's a specialist trainee in the Midlands. So our first talk after the break is from Dr. Kawasar, who's working at Chelsea and Westminster Hospital. And the title of the talk is Checkpoint Inhibitor Associated Bullous Cutaneous Adverse Immune-Related Events, a multi-centre observational study. So thank you very much.
Thank you for the kind introduction. Okay, so it's a pleasure to present this multi-centre study on behalf of the Royal Marsden Hospital, Oxford University Hospital, Royal London and Christie Hospital NHS Foundation Trust on checkpoint inhibitor-associated bullous adverse events. So immune checkpoint inhibitors targeting PD-1, PD-L1 and CTLA-4 have demonstrated exceptional anti-tumour activity in numerous solid and hematological malignancies, resulting in marked survival benefits. However, these agents have led to a unique spectrum of side effects termed immune-related adverse events. Cutaneous side effects are among the most prevalent immune-related adverse events, occurring in up to 50% of patients using checkpoint inhibitor. However, rarer but severer reactions, including bullous pemphigoid, have been reported. And treatment of these bullous disorders pose a challenge for clinicians when balancing oncological versus dermatological priorities. So what do we already know in the literature? Checkpoint inhibitor-associated bullous pemphigoid is rare, and information on the incidence risk and their impact on patient outcomes in larger populations are unknown. Prior studies are limited to case reports or case series from smaller single institutions describing rates of between 1% to 8%. So we conducted a retrospective observational study between 2006 and 2019 of adults across all tumour types who received checkpoint inhibitor therapy with associated bullous pemphigoid or any bullous cutaneous eruption during their treatment and up to 12 months after discontinuation. So we collected data on demographics, primary malignancy and BRAF status where relevant, checkpoint inhibitor therapy, clinical features, the onset and duration of symptoms, histopathology and direct or indirect immunofluorescence, the treatment, outcomes, tumour response, and additionally, we reviewed data regarding the response rate and overall survival for cutaneous melanoma. So what did our results show? A total of 7,391 patients received checkpoint inhibitor treatment, and bullous immune-related adverse events were found in 22 patients. Of these, 16 cases were bullous pemphigoid, confirmed on biopsy with immunofluorescence, and 1 case of lichen planus pemphigoides. We were left with 5 cases that did not fulfill the criteria of bullous pemphigoid, as 3 had a negative direct immunofluorescence, and 2 cases did not consent to further investigations. The median age at the time of diagnosis was 76 years old, and among these, 73% were males and 27% were females. Anti-PD-1 therapy with pembrolizumab was the most frequently associated with bullous toxicity, and BRAF wild-type melanoma was the most common underlying cancer in 59%. 91% of patients experienced prodromal pruritus, and 82% developed bulli. Non-specific cutaneous rash and urticarial lesions were also noted. The most common affected sites were the lower limbs in 41%, and importantly, mucosal involvement was noted in 27%. So the government's cancer adverse events criteria suggests bullous dermatoses should be graded according to symptoms and the extent of blistering, and most patients were grade 2 and 3 skin toxicity. The median time of onset between starting the checkpoint inhibitor therapy and bullous disease was 12 months, and the median duration of symptoms was 6 months. And although most cases developed during the course of immunotherapy, we had 2 cases occurring within 3 months after completion. So a skin biopsy was performed in 91% of our cases, and of these, 14 were positive for direct immunofluorescence. And in those without the skin biopsy, 2 patients had a positive indirect immunofluorescence. Nearly all patients were treated with topical steroids, with a very significant number needing oral corticosteroids. Very few required steroid-sparing agents, including mycophenolate mofetil. And additional treatment agents used were doxycycline or limacycline and nicotinamide. And additionally, to manage these cases, checkpoint inhibitor was permanently discontinued in 55% and interrupted in 20% due to bullous toxicity. Patients were re-challenged with the same checkpoint inhibitor after initial stabilization of cutaneous symptoms, and the bullous eruption reflared in 50% of our cases. Tumor responses revealed 77% had stable disease, and only 14% died of disease progression. Interestingly, complete or partial response of cutaneous melanoma was achieved in 94% of patients, with a median overall survival of 40 months. Additional immune-related adverse events were seen in a small number of patients, including alopecia areata. So this is the largest UK retrospective study, and our data suggests a rate of 0.3%, which is lower than previous smaller studies reported. However, the prevalence of bullous pemphigoid in our study is notably higher than in the general population. And as with classical BP, we have found an association with increasing age. However, in our study, there was a male predominance, unlike classical BP, where females are more affected. So the exact pathogenesis of checkpoint inhibitor-associated bullous pemphigoid is unknown. One proposed theory is that the PD-1 signaling obstructs the binding of the tumor antigen to its B-cell receptor, therefore reducing further B-cell expansion. Blockage of PD-1 enhances the B-cell receptor response, leading to expansion and subsequent antibody production, with cross-reactive immunogenicity against the skin basement membrane. We found bullous immune-related adverse events are most common with patients receiving treatment for cutaneous melanoma, consistent with previous studies. And one previous study showed that bullous pemphigoid associated with these checkpoint inhibitors are 2.2 times more likely to occur with cutaneous melanoma compared to those with lung cancer, possibly as these agents have been approved longer in the melanoma patient group. In addition, we have identified other underlying cancers which have not been reported yet. And out of our melanoma cohort, 81% were BRAF wild type, which has not been previously looked at before. And BRAF wild type is now recognized as being more commonly seen in the older age group. So some important clinical findings in our series are that prodromal pruritus is a prominent feature and that 25% of patients with bullous pemphigoid did not develop bulli. Mucosal involvement occurred in over a quarter of our patients, a finding higher reported than in the literature. And it's also important to note that bullous eruptions with checkpoint inhibitors are not always bullous pemphigoid. Negative direct immunofluorescent associated cases have been reported in the literature, and therefore our 3 cases may have also represented bullous pemphigoid. So the timing of onset of bullous immune-related adverse events appears much later compared to other cutaneous findings, and our findings reveal double the reported time of onset compared to previous observations, which may occur as late as 27 months. We also compared a single-agent therapy, which has a longer time to onset, versus a combination therapy, and it can persist up to 3 months after discontinuation. So the most effective treatment has yet to be established and often requires long-term therapy. Potent topical corticosteroids are the commonest first-line treatment, often with the addition of doxycycline 200 milligrams per day. However, the use of antibiotics in patients on checkpoint inhibitors is also controversial due to the possible effects on the gut microbiome, with consequent effects on tumor response rates. Therefore, choice of treatment should be consideration in management decisions. In uncontrolled bullous pemphigoid, addition of oral prednisolone with subsequent weaning is widely accepted, and a variety of steroid-sparing immunosuppressive agents has also been reported. However, despite this, interruption of checkpoint inhibitor is often needed. Symptoms may still persist for 6 months. However, there is a silver lining, and of the cutaneous melanoma cohort, 94% achieved complete or partial control with a median overall survival of 40 months. Nelson et al. Reported 12 patients with checkpoint inhibitor-induced bullous pemphigoid also had improved tumor responses. However, larger studies are needed to confirm whether the development of bullous immune-related adverse events are associated with a better prognosis. So in conclusion, Bullous immune-related adverse events are rare, but an emerging entity occurring in 0.3% of patients in our study. Clinical presentation may vary, with pruritus and non-bullous variants appearing similar to other cutaneous toxicities. Therefore, checkpoint inhibitor bullous pemphigoid may be significantly underreported. Prolonged latency is a unique feature and can occur after discontinuation. An interruption of checkpoint inhibitors is often needed to manage these cases. Our study demonstrates this occurs mostly in men, older age groups, and is associated with the BRAF wild type in melanoma patients. And it's important for clinicians to recognize this condition promptly, so early optimal management is initiated to reduce interruptions to immunotherapy and improve overall patient outcomes and tumor responses. Thank you.
Thank you very much. That was a very clear presentation. I think Dr. Coulson has a question for you.
Thank you very much. I've only had one of these cases, Ian Coulson from Burnley in Lancashire, and actually the oncologist had a reticence in us using oral steroids rather than antibiotics because the oral steroids might negate the effect of the checkpoint inhibitor. Though obviously you suggested that antibiotic effects on the microbiome might reduce the efficacy of the checkpoint inhibitor. So any comments about that? I think the literature does kind of suggest perhaps being careful with steroids, oral steroids.
Yeah, thank you very much. So that is correct. We have to kind of weigh up the oncological versus dermatological priorities of that. So I think it's by case discussion from that with both parties.
Thank you. We've got another question over here.
Yeah, thank you for that presentation. I noticed that only half the patients who were challenged got the eruption when they got the drug again, and 50% didn't. Do you have an explanation for that?
I'm not sure, actually, if there's any underlying pathogenesis why that might have happened. There have been studies where they've suggested that the autoantibodies have remained in the patient's system, and so that might have reflared a lot quicker. But not particularly sure if there's a specific reason for it.
All right.
Maybe my consultant would be able to.
Yeah, go ahead.
No, it is really interesting that, but it also happens with the other dermatoses as well. You can re-challenge them and they don't get the macular papular rashes and things like that. So there is something going on whereby you can sometimes re-challenge these patients and they don't get the same dermatosis again.
Thank you. I just wondered, are you observing these patients longitudinally, just because obviously with the hint that prognosis is better if you do get some of these adverse reactions, but with 50% possibly having to stop? Is this an ongoing longitudinal analysis? Or?
We're not doing that at the moment currently, but that's definitely something to consider in the future.
Well, thank you very much. That was an excellent presentation. Before you disappear off stage, we'd just like to award you with your memento mug. So next we've got a plenary lecture, and I'm delighted to introduce Professor Shanaz Walton. I'm sure all of you know Shanaz. She's been a consultant dermatologist working in Hull and East Yorkshire since 1997, and she was awarded an honorary chair back in 2016, and I think that was a reflection of a great amount of clinical academic work that she's done, particularly translatable work, such as being very involved in NIHR studies and bad beer. And I know, Shanaz, you were recently honoured by yesterday with a further award from the UK Dermatology Clinical Trials Network. So we're really looking forward to hearing your presentation, which is titled Clinical and Research Snippets from a Career in Dermatology. Shanaz, over to you.
Thank you, Richard. Good morning, everybody. I hope you will join me on my journey. I'm going to show you interesting clinical cases and research that I've picked up at different stages of my career, which I'll be highlighting as I go on. Declaration of interest, but none of them applicable to this lecture. For those of you who don't know me, I was born in Mumbai, and here I am with my identical twin and my mother. I decided, when I was a second-year medical student, I decided to do dermatology at that stage because our medical school hosted an international conference, and I was picked out to look after foreign delegates. So between pinning badges and tying shoelaces, I was watching the presentation, and I was very impressed. So from then on, it was dermatology. So my first case that I take you to is I did my elective in my 4th year medical school with a consultant. And this patient was an inpatient and presented with these umbilicated papules scattered all over his body. I won't tell you any more about his history at this stage, but I will come back to it. I was told at the time that the consultant with whom I was doing my elective did not like women in medicine, so I had to keep my mouth shut and not challenge his diagnosis. So I tried my best. And what he did was he told the registrar to do a biopsy, and he looked at me and said, "This is the only way you'll be able to convince this girl that I'm correct." Anyway, I didn't say anything. The biopsy was done, and histology came back as a fetal fat cell tumor, a hypernephroma, which certainly this wasn't. Now I'm going to tell you that I did present the history fully on the ward round, and the patient had Hodgkin's disease and was a pigeon fancier. So at that stage, I just couldn't keep quiet. So I asked him if I could take some of the material from this papule and do my own staining. I had acquired a little corner in the anatomy lab for my work, and the animal lab was next door. So I put the material on a slide and stained it with India ink and saw this budding yeast, which is Cryptococcus neoformans, which I then injected it into a mouse and produced the organism again from the brain of the mouse. And this case was then published in the Indian Journal of Dermatology much later. I did my MD on the mast cell, and I did most of my pilot work as a medical student because at the time there was no staining available for mast cell in Mumbai. And I went through various stains like Giemsa, Alcian blue, and settled down with 0.1% toluidine blue, standardized the technique so that when I qualified, I could go straight into the actual work. Here, this is just a small snippet of the MD thesis. The females are triangles, the males are dots. The face is depicted as an F, an arm. And as you can see here, there are definite site, sex, and age differences, which was the first study of its kind. The face had more mast cells than the arm. Females had more mast cells than men, and they dropped with age. In 1976, I decided to come to the UK because research was very difficult. There was no color photography. My samples at all had to go to Japan for photography. India insisted we vasectomized all patients who came to the hospital, however ill they were, and that did not fit in with my moral obligations to my profession. So I decided that this was time to leave. So this was taken at the airport at midnight, and my parents were looking extremely worried because the Indian government only allowed me to come to England with £2.46, and that's all I had when I came. So if you look at the bottom of this artistic representation, I arrived at Heathrow with my MD and my £2.46, and then was lucky enough to get a busy 1-in-2 job as a house officer in medicine. I had a choice of either doing the PLAB or doing the house officer, so that's what I did. I did it with Dr. Ferryman, who is the Ferryman and Galway hirsutism scale person, which I used again later on in my own research. I then went to see Robin Eady at St. John's and said, I want to continue with my mast cell research. And he sent me back saying, look, you first got to do your MRCP and general medicine and clinical dermatology, and then you can come back to do research. So from then on, I decided to do general medicine. So I took up a job at Hull. It was an 18-month rotation between gastroenterology, dermatology, and rheumatology. And this is what Hull Royal looked like in 1977. And in 2022, to my dismay, it looks like a concrete block. Now, at the time, I used to go to North of England meetings, and I used to collect all the books. And I preferred to publish series rather than individual cases. So when I came across 3 patients with hyperkeratinemia in Hull, I approached Neville Rowell and Donald Williamson because they had a case each which was presented at the North of England and made up a series. And they all had one thing in common. They were nurses, and they were anorexic, and they had high levels of beta-carotene. Sometime later, I came across the second patient where you can see the can of soup. The BMJ were very interested in the second patient, and they actually published my can of soup on their front cover of a Christmas issue of the BMJ at the time. And the reason for that is in the next slide. As you can see here, the bottom figure is the lycopene, which is the carotenoid we found in the patient with the tomato soup. And it has a double bond at the final CH3 position, which is lacking in beta-carotene. And that double bond stops the lycopene to be converted to vitamin A. So you do not get hypervitaminosis A if you drink gallons of tomato soup. I got into a little bit of trouble with that because after the BMJ publication, the Sun newspaper picked it out and put this nude woman on the page 3 and said, "Tomato soup for a quick tan." The patient then rang me and said, "Is this me you're talking about?" And I said, "No, not really," because no patients were named. So after finishing my rotation, I decided to continue my medical jobs till I got my MRCP. So I went to Otley to do a medical registrar job. I was trying to follow my husband-to-be because he went to Leeds and I went to Otley. And Otley was a small hospital. They had no dermatologists. A dermatologist visited from Bradford once a month. So I went round and told everybody that I was interested in dermatology, so please refer everything to me. And cases poured in. So the next patient is one of my patients from Otley in my medical registrar job. A 64-year-old lady presented with this profuse watery diarrhea and vomiting, weight loss, and this rash. The rash immediately sent signals in my brain and said this could be necrotizing rash due to a VIP syndrome. That was very fresh at the time from Stephen Bloom. And so I proceeded to do a VIP assay. And to my surprise, it came back extremely high at 400 level, normal being up to 30. Abdominal X-ray showed this mass, which I've drawn with arrows on the kidney, left kidney. And then, Otley being a small hospital, I then contacted the gastroenterologist at Leeds, who then took the patient over and did a celiac axis arteriogram, and then removed that kidney. And it was a renal vipoma, which was extremely rare, and the case was then published in the British Medical Journal, and I was fortunate to be asked to be an author on it. The patient, unfortunately, died from septicemia post-op. So, after my job, by then I'd got my MRCP, so I thought it's time to get back into dermatology. So I got a job as a registrar in Newcastle. My husband, being a Geordie, told me to go to Newcastle because it'd be more difficult for me than him. And then I got the job and he didn't. So I finished my 2 years and then went back to follow him around. So in Newcastle, I spent a comfortable 2 years doing my clinical work and my research. And one of the things I did was sweating and sebum excretion. And there was a distinct difference between males and females in the sweat in sweat rate, which was an irreversible effect of androgen on gene expression. What in fact it was that females sweated 2.5 times less than males, and prepubertal eunuchs sweated like females. But when you looked at post-pubertal eunuchs, and these were rapists, and I have visited every prison in the country to find these rapists. I went to the Manchester prison, I went to the London prison, and collected all the rapist sweats. And they sweated like men. They were on high doses of ciprotron to block their testosterone. In Newcastle at the time, we saw lots of patients with arsenical keratosis, which they had arsenic in their younger days. There used to be a chemist called Dirty Dicks. And I got one of my artist patients to draw me an artistic diagram of Dirty Dick. And Dirty Dick used to dish out arsenic in tonics, in cough medicines, in everything. And then it was obviously closed down. So after my time in Newcastle, I then got my senior registrar job back in Hull, because by that time, my husband was back in Hull. And I had 4 days in Hull and 1 day in Leeds for research. And I spent quite a lot of my time on M62 collecting speeding tickets. And at that stage, I decided to also have my children, because I was by then married in Newcastle. So I had done some contact dermatitis work in Newcastle with copper, and I continued that with some HLA work with nickel and an epidemiological study in gold patch testing. So metal patch testing is what I continued with. And this study, which was published ages ago, was on HLA-B and DR antigens in nickel-sensitive females, because nickel was such a common condition. And I won't go through all of it. I've just highlighted a bit to show you that a comparison of patient antigen frequency versus the Yorkshire region HLA figures showed an increased incidence of HLA-B35 in our patient population. And there was no significant association between the DR antigens and relative risk in our patients. And again, there was no significant association with the etiological fraction. I then went on to do some work on genetic control of sebum excretion and acne, a twin study. I was very fortunate because there was a twin register kept by one of the pediatricians, and all these twins were about between 12 and 14, the acne group, when I started doing this work. So it was very easy to access them. Again, looking at just sebum excretion, there was no difference between identical and non-identical. They were much the same. But when you looked at the acne grading, it was all over the place in both groups, suggesting that there were also environmental factors and it wasn't all just genetic. I also continued the acne work, looking at clinical ultrasound and hormonal markers of androgenicity in acne. I was very fortunate to be able to be working with Bill Cunliffe at the time. And we worked in collaboration with London. And again, there were 36 females that were studied, and they were divided into groups according to their degree of acne. But only 2 patients, the whole group, had polycystic ovaries on ultrasound, because at the time they said that polycystic ovaries were very common in patients with acne. 7 patients had irregular periods, but none had evidence of hirsutism. And multiple regression analysis determined that the best model for predicting acne score was delta-4 and dehydroepiandrosterone, which showed positive effects with a negative effect of sex hormone binding globulin. And the findings in the 2 patients with polycystic ovaries did not differ significantly from those in the remainder of the patients. And this is just a statistical regression diagram just to show you that the 2 patients in red with polycystic ovaries were not outliers, they were all within the group. when I came back as a senior registrar in Hull, I renewed my contact with Dr. Bennett, with whom I'd done my gastroenterology SHO job, and he had a specialist interest in esophagus. So I went to him and said, I would like to work with you on skin and esophagus, even though I wasn't working with him at the time, but he was very, very helpful. So I did an endoscopic study on lichen planus and the esophagus. Also looked at rosacea and ulcerative colitis. I was fortunate to be asked to do an editorial on skin and gullet, which was published in their journal, and also looked at esophageal involvement in Behçet's. I'm not going to go through all this, but this picture that was published in the BMJ shows you an erosion at the lower end of the esophagus in somebody with severe lichen planus. And there were 19 patients altogether, and they were typed according to their skin lesions and the mouth lesions. And they're all on there. 5 patients had esophageal lichen planus. 3 had papular lesions in the lower third. 1 had papular lesions throughout the esophagus, and 1 had severe erosive change. pH studies showed no change in acid reflux. There was submucosal involvement in all 4 patients, and the patient with severe erosive change had a mixed infiltrate extending into the fibromuscular tissue. I also continued collaborative work with a histopathologist in Hull and looked at various bits, but particularly of interest is the Spitz nevus, looked at 29 patients, all from Hull, and also did an audit comparing skin biopsies that dermatologists did and GPs did. At the time, it was very topical. GPs were just beginning to do skin biopsies, and surprisingly, that they were very good, actually. And at the time, also wrote an article on emerging epidemic of skin cancer in Hull. Now, I had a number of patients who would come with their heads covered in scarves. So my advice at this stage would be never ignore a patient who comes with a scarf, try and take it off. And this patient came with this appearance. At the time, I was a senior registrar and obeyed my consultant, who said, do a biopsy. So I did a biopsy, and the histology came back as brain tissue. So I was terrified. And then came, is it not moving? This is supposed to be a video which is loaded but not moving. Can you get it to work? If not, we'll move on. It shows the pulsating brain in the center. No? Okay. Ah, there you are. Can you see? If you look at the center, the brain is pulsating. So that was that. And 3 patients presented with this sort of problem, and I wrote them up in the BJD at the time as extensive and fatal basal cell carcinoma, because basal cell carcinoma is not meant to be fatal. And there was reported 3 cases, all with the same presentation. Then I come to my consultant job in Hull, and this patient comes along. It looks like nothing on earth when you look at the clinical picture, but it felt rather indurated. So did a biopsy, and we reported it as an asymptomatic pink plaque on the cheek, and the biopsy revealed a desmoplastic malignant melanoma. So if you see anything unusual, biopsy. And this was reported. This is an interesting patient. She had come from outside the area. She was referred to me. I was on the 4th dermatologist. She'd seen 3 dermatologists before me and 2 ENT surgeons. The ENT surgeons kept lopping off bits of her ear. The dermatologist kept injecting topical steroids. And when she came to me, she looked like that. Again, she had a scarf on her head. So again, suspicions arose. And when I looked at her, it reminded me of the turkey ear that was described in the Rook textbook by David Gockroger at the time, saying that this was a sign of sarcoid. Well, I thought at the time that it was tuberculosis. So I sent another biopsy to Newcastle, where they have a special lab. And that was the only place where they could actually find one Mycobacterium tuberculosis in the specimen. And then treating her, it completely cleared. And her final words to me when I discharged her was, "I wish my husband had seen me like this, because for 40 years I'd covered my head with a scarf." So there you are. So again, beware of a lady with a scarf. I then wrote to David Gockroger and said, "You've got to change this in your book chapter." And he's then put it down as what we said, it's a sign rather than sarcoid. So Turkey here, is it a diagnosis or is it a physical sign? We think it's a physical sign. And this was published in the BJD. The next patient was published in a plastic journal because the patient was in a burns unit and had developed extensive sarcoid in the scars of the burns tissue. And histology confirmed that. And it was quite unique to see the whole body covered, all scars were covered in this sarcoid. This case I only added last month because it's only been published last month. This was a mother of one of the local GPs. He met me at a wedding and said, "Can you see my mother?" At a wedding, it was very difficult to see her because I couldn't really strip her. So I called her to the department where we could take a proper history. And there was this dominant pattern of inheritance of what looked like blackheads. She was extremely dark complexioned, so it was very difficult to pick out the blackheads, but you could still see them. And when you did a biopsy, we showed this proliferating lentiginous pigmentation of the basal melanocytes. And this was then written up last month as Dowling-Dego's disease. And I got a number of requests from Asian colleagues to see their relatives at social functions, which I politely declined. This is just to show you a pitfall of teledermatology. I'm not a teledermatology fan. This patient was treated by one of my colleagues as discoid eczema, but he wasn't given the X-ray. He was just given the clinical photo. After 6 months of Dermovate, he got no better and was referred to me. Clinically, it looked like a granulomatous eruption, suggestive of sarcoid. I did a biopsy to confirm it, and X-ray was self-explanatory. I then moved on to working on research. In translational research, this Professor Jonathan Barker has lent me this slide. Shows you the clinical benefits of translational research, which help you to target your therapy to the patient. And this is his slide again, showing how the SAW1 gene is located on the HLA locus, with interleukin 12, 23R, and 23A playing a role. So I devoted my time to collecting data for multi-center studies and translating the research finding into care protocols and involving patients and public. I believe patients are very important. So collecting data for multi-center studies, bad beer, I'm not only the principal investigator, but I'm also on the steering and the data monitoring group. And we are involved in that, and also in BSTOP, which are the biomarkers for systemic outcomes. One collects the patient data set, and the other collects biological samples. I was also involved in the acne genetics study, and I was one of the centers with the largest number of patients for this study. And various genes were identified. You must have seen the paper that was written in Nature. And I've been involved in several UK DCTN trials. The patch 1 cellulitis study showed that in recurrent cellulitis, there was a 50% reduced risk of recurrence when on prophylaxis, but which was lost over the following 2 years. And this was published in the New England Journal. Then the pyoderma gangrenosum study, which was another epic one, which compared cyclosporin to prednisolone. And 50% of patients in both groups healed after 6 months. So neither treatment was particularly good. But there were only 2 SAEs in the cyclosporin group and 7 in the prednisolone group, mainly infections requiring hospitalization. And sadly, one of our patients died during the trial. Again, I took part in the Venus 4 study, which showed that 2-layer compression stockings were as good as 4-layer bandages. And that obviously is cost effective. You don't need a nurse to put 4-layer bandages, and patients can do it themselves. And this was published in the Lancet. And a very good study by the UKDC10 that I was very proud to be part of was the bullous pemphigoid study, or the blister study. Again, we were the recruiting center with the largest number of patients. And the secret there was I used to work on Sundays going through GP letters and often call the patient the next day, which was Monday, before the GP had a chance to put them on oral steroids so that we didn't lose them from the trial. And that, again, was a non-inferiority study, which showed that doxycycline was as good as oral prednisolone, particularly, and safer in the long run. And this was also published in the Lancet. I believe that patient public involvement is very important. And this is a notice we have outside the department that if they are interested in research, they can either contact me or my research nurse at the time. And today's research being tomorrow's treatment. And we had fortnightly meetings with patients who are on various trials to ask them what their thoughts were, how things were progressing, so they felt involved. Again, to do this effectively, you have to produce teams. So I produced various teams to look after different trials involving junior doctors or nurses. Our nurse in the first picture is at the BAD. I don't know whether she's here today. And this is our team. And I think if I can give one message, that networking and working in teams is extremely important for research. And I'm ever so grateful to Hywell Williams, who you all know. He's been my mentor throughout my consultant post, and he is the one who has converted me from being a simpleton to a researcher. So I'm very grateful not only to Hywell, but also his team, which includes Karen and Maggie. And I'll leave you with a slide of Hull, just to show you that Hull is not the end of the world. It was City of Culture in 2017. It was the same year that Hull played Arsenal in the FA Cup and lost. But I'm a Newcastle supporter, so that concerned me. However, our patients drink a lot of alcohol, and they're obese. Hull is the obesity capital, and that gives us tremendous problems when we're treating our psoriatic patients. So with that, I will leave you with a thank you also for P.U. Banerjee for inviting me to speak today. So thank you.
Thank you very much, Shanaz, for that amazing story. We've got time for maybe one quick question, if anyone has a burning question. If not, Shanaz, that was fantastic. Really appreciate it. And before you disappear, we just need to give you a little memento.
Oh, all right. Thanks.
I would like to introduce our next speaker, Dr. Marietta Papanikolaou, who is a clinical research fellow at King's College London and winner of the BSID Best Paper. She will be presenting on immunoglobulin E as a potential driver of itch in dystrophic epidermolysis bullosa pruriginosa through autoimmune inflammation.
Thank you. Hi, everyone. It's really great to be back here in person. Thank you so much for this invitation. I have no conflicts of interest to declare, and this is the rough structure of my talk today. So I'll start with a general overview of the problem of itch in epidermolysis bullosa, followed by our particular study's background and aims, the methods we used, and finally some of the most important results in both blood and skin. So itch is one of the most troublesome complaints of people who live with EB. Considering the extent of the problem, relatively little has been published in literature on this. These are some of the biggest studies that have been conducted to date, involving 40 patients for the one on the left and just over 140 patients for the one on the right. And importantly, what they demonstrated was that both the incidence and the severity of itch in EB across all types are comparable to those seen in atopic dermatitis. And this is the case particularly for dystrophic and junctional EB. In this figure, we tried to summarize published evidence pertinent to itch mechanisms at molecular level in epidermolysis bullosa of all types. So to summarize what's happening here, the triggering event, of course, is a mechanical injury, so a separation of the epidermis and the dermis, or in other words, a blister, that triggers keratinocytes to produce a range of pro-inflammatory cytokines that are then released into circulation, but also into the dermis, and act locally to firstly recruit immune cells to the affected site, but also stimulate lymphocytes to produce more cytokines. And you can see in the central portion here the key immune cell types that are involved in this process. And those in turn generate a further wave of inflammatory cytokines that eventually bind onto their respective receptors on nerve endings in the skin, triggering itch signals that then travel to the central nervous system and create the sensation of itch. In our particular case, we focused on dystrophic EB and specifically the clinically distinct, extremely itchy subtype of this known as pruriginosa. The term was coined in this 1994 publication in the BJD. Almost 200 cases have been reported in worldwide literature since, and we also identified 69 such cases recorded in the UK. Despite this, what causes the itch in pruriginosa remains unknown. One of the first things that caught our attention when we were looking into the characteristics of these individuals is that over 80% of the UK cases and more than 1/3 of the literature cases have been reported to have raised circulating IgE levels. So we set out to explore the role of IgE in pruriginosa-associated pruritus. In terms of our methods, we organized a case control study for this purpose. We recruited 15 individuals with the pruriginosa phenotype and confirmed mutations in the gene encoding collagen 7, along with two control groups, one of individuals with dystrophic EB but not itchy skin, abbreviated here as DBMP, and a second control group of completely healthy volunteers. And as you can see, both groups were matched as closely as possible to the pruriginosa participants for age, gender, and ethnicity. We collected blood and skin from all participants, or in the case of skin, participants who had suitable areas to biopsy and were happy to provide biopsies. And I'll start with some of our results in blood. So the first thing we did, of course, was to measure total IgE in the circulation of all participants. The red line here represents the median, whereas the blue dotted line is the maximum normal as set by our diagnostic laboratory. And fully in keeping with what we'd seen in the literature and UK cases, the pruriginosa participants had indeed raised IgE levels compared to both control groups. So 13 out of 15 of these individuals had levels above the maximum normal. And for most of them, these were levels comparable to those seen in urticaria. So this generated a number of questions, in particular, what are those antibodies targeted against? Where are they produced? Are they functional or just an epiphenomenon? And finally, are other immunoglobulin classes involved? So we started by investigating the latter question, which was probably the most straightforward to address. And these are the levels that we saw for immunoglobulins of all classes. So there was a slight rise, as you can see here, in IgA and IgG in the pruriginosa group compared to the control cohorts. However, most of these values were still within normal limits, and the difference was not nearly as striking as that seen with IgE. there was no difference in measured levels of IgM and IgD. So this picture kind of makes sense in that we know that both IgA and IgG are precursors to the production of IgE. Next, we investigated whether the IgE might be targeted against environmental allergens. So are we essentially looking at an allergy here on the background of EB? So we used the ISAC assay to measure specific levels of specific IgEs against a panel of over 100 allergens of different types. And this rather busy table here summarizes the results. The gray areas are participants with total Ig levels less than 20, which we decided to exclude from the experiment, feeling that they were unlikely to yield meaningful results. And the bottom line is that for the pruriginosa cohort, which you can see on the left, in spite of these individuals having the highest IgE levels, and the majority of them having raised circulating IgE, in only 4 cases we detected specific IgEs against environmental allergens, and we had 1 for each case, as you can see, at low levels. And this contrasts with the picture seen on the far right in the healthy volunteers, most of whom had detectable IgEs against several allergens and at moderate high levels. So this kind of picture suggests that circulating IgE in pruriginosa, for the most part, is not directed against environmental allergens. So moving to what we saw in skin, our tissue of interest, we collected lesional biopsies here and site-matched non-lesional biopsies from the pruriginosa participants, site-matched lesional biopsies from the non-pruriginosa participants, so this would have been lesional non-itchy skin, and finally site-matched biopsies from a number of healthy volunteers. And we started with a preliminary experiment. We used immunofluorescence to investigate the presence of immunoglobulins of all classes, including IgG subclasses, in these skin samples. To determine this, we compared them to a bullous pemphigoid positive control. And if they had fluorescence that was comparable to the positive control, they were deemed positive. If there was no fluorescence there, they were negative. And finally, if there was fluorescence, but less so than in the positive control, they were marked as equivocal. This table summarizes the results for the pruriginosa lesional samples in particular. The non-pruriginosa and healthy volunteer samples were largely negative for all these classes, so we haven't included them here. And what we can see is that IgE was actually detected in the majority of the pruriginosa lesional samples, as opposed to the rest of the classes where most of the samples were negative. So moving on from here, we repeated the immunofluorescence for IgE, but this time stained for interleukin-4 simultaneously. And again, in keeping with our earlier findings, there was an increased count of IgE positive cells in the dermis, in the pruriginosa samples, both lesional and non-lesional, interestingly, compared to both control groups, and this result was statistically significant for the comparison with the healthy volunteers. I hope you can also appreciate that this was associated with an increase of epidermal expression of interleukin-4, which is the red color here. So not knowing what the IgEs were targeted against, we were unable to test their functionality in vitro, but we instead decided to do that in vivo, essentially, with a trial of an anti-IgE therapy in one of the individuals in the pruriginosa cohort. So we were successful in securing funding from the NHS England via an individual funding request for this female, who was in her early 20s, and had a baseline IgE level of 377. These are photos of her legs at baseline. And we have repeat photographs here, 2 and 3 months into treatment on the far right. And we felt there was a visible reduction of wounds there, so improvement in wound healing, with reduction of the background erythema. And this was indeed associated with improvements in all of her itch scores and her inflammatory markers. So in conclusion, our findings to date support that IgE levels in both blood and skin are increased in pruriginosa individuals compared to both non-itchy dystrophic EB and healthy volunteers, and that these are, for the most part, not directed against environmental allergens. Based on these observations, we hypothesize that IgE in pruriginosa is directed primarily against autoantigens, and that it promotes skin inflammation and hence itching via an autoimmune mechanism, and therefore it is a potential target for anti-itch therapies in pruriginosa. I'll close by thanking everyone who very kindly contributed to this work, and thank you very much for listening.
Thank you, Marietta, for a very clear presentation. We have a question for you.
Hi, Eugene Haley, Southampton. Are you familiar with tertiary lymphoid structures? They're structures like lymph nodes, or similar to lymph nodes in skin. You see them in cancers, etc. And it's where you've got collections of B cells, and you have some surrounding T cells and antigen-presenting cells. And there is some evidence in mice that they actually can be associated with class switching to IgE. So I'm just wondering, have you looked for any tertiary lymphoid structures in the pruriginosa group, and whether that might explain why you've got this sort of IgE there?
We haven't, actually. The other thing that we're in the process of doing is staining at the moment for various cell types, because we don't, within the skin, their skin at the moment, we haven't yet determined what the primary cell types are there. So this is work in progress, but it is.
Yeah.
Sorry?
Talk to us afterwards. We've done stuff on it, not on EB, but yeah.
Sure, thank you.
One last question.
Congratulations, really great work and very interesting results, of course. Do we need to reclassify EBP as autoimmune condition?
Very good question. Very tricky one. I think we, at least in part, we might need to. Of course, I think the pivotal point will be to identify what the IgEs are targeted against, and therefore confirm that there is an autoimmune mechanism there before we go that far. But it's a possibility, and it's a very good question.
Brilliant. Thank you very much, Marietta. We'd like to present you with your commemorative BAD Cup. I'd like to introduce our next speaker, Professor Girish Patel, who is a consultant dermatologist at the Welsh Institute of Dermatology, University Hospital of Wales, and honorary professor in Cardiff University. He trained in dermatology at the St John's Institute of Dermatology, Welsh Institute of Dermatology, and National Cancer Institute. He is the recipient of a number of awards, including the Geoffrey Dowling Fellowship, the most prestigious fellowship awarded by the BAD. His research group study cancer stem cells in the common human skin cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma.
Thank you for the introduction, and thank you for the opportunity to present our work. So, my disclosure. So basal cell carcinoma is what I'm going to concentrate on in today's talk, this only because this is our most recent findings and we think it's quite exciting and relevant to the audience. Obviously, Nick Lavelle highlighted the problem when he said that basal cell carcinoma is like the elephant in the room. We're always chasing USC targets and RTT targets, but actually the incidence of basal cell carcinoma rises by 6% every year. And more importantly, when you look at, or what Nick looked at, what his cohort in Norwich consisted of, it represented an annual incidence greater than all other cancers added together. So the workload is huge. Added to which, there's morbidity. Whether we accept it, we can always cut out basal cell carcinoma, but there are consequences. And there are incurable diseases, like my patient at the top who has a recurrence of a basal cell carcinoma that is around her internal carotid artery, or my patient down below who has Gorlin syndrome. As you can see, Richard has been putting Mohs grafts on my patient for a while, but I mean, it's not a solution long term. Okay, so what do we know? Basal cell carcinoma, we diagnose it very easily, really. It's not that difficult. And despite the fact that it's the tumor with the highest mutational burden, what we do know is that there is a key driver pathway called the hedgehog pathway, and that mutations within patch, which is the commonest cause, or an activating mutation in smoothen switches on this pathway, and it continually signals down. And pathologically, we kind of get an appearance of almost a homogeneous tumor, cells that look fairly monomorphic. And yet what we found when we studied this in more detail is that if we look at the hair follicle keratins, which are not expressed elsewhere in any other tissue, we find that basal cell carcinoma demonstrate hair follicle differentiation. And they're, or at least in the work, we hypothesized and I think showed experimentally that the thing that was missing from full hair follicle differentiation was the fact that there were no dermal papilla signals, and that was missing. We could find the switch. Anyway, this led us to then make the next hypothesis, which is that if hair follicle stem cells, CD200 positive there in the bulge, can recreate and regenerate hair follicles, then are there CD200 BCC cells that can drive and recreate basal cell carcinoma? Yes, as in, these are the drivers for the tumor growth. So we identified CD200 positive basal cell carcinoma subpopulation that represented between, well, up to 2% of the population. 98% of the population were negative. And then if we put in the negative population, we found in a xenograft model, we found that it could not recreate the tumor, i.e. they were all differentiating. And that if we took that small 2% population and xenografted it at very low numbers, so 3 million negative cells don't give rise to tumor, but we can get reproducible growth with 1,000 cells of the CD200 population, suggesting that CD200 positive basal cell carcinoma are probably cancer stem cells similar to the hair follicle bulge stem cells. And our most recent, and this is our unpublished work, it plays with single-cell sequencing. So single-cell sequencing involves taking tissue, flow sorting it, and then barcoding individual cells, and then doing RNA sequencing on individual cells. And what you can get is a transcriptional profile for each individual cell. And then looking at the individual cells, you can cluster them based on a spectrum of signature transcripts. And so we've color-coded this. So here we have epidermal keratinocytes. We have some hair follicle keratinocytes in the green and the purple there. We have melanocytes, endothelial cells, and fibroblasts. And it's a small number, but there we are. So now we've taken, that's our hair follicle. And here we have basal cell carcinoma sample that we've done the same thing through. So we've now taken single cells from a basal cell carcinoma sample, and as you can see, we've collected some normal cells and some endothelial cells and fibroblasts, but we're using the pathologist BER-EP4 marker. We can see that we've clearly clustered off and picked off a tumor population, and that's there down here where we originally saw, if you remember, the hair follicle set. And we can validate that by looking at hedgehog downstream signaling genes. So we can say, okay, if hedgehog signaling is activated in all basal cell carcinoma, what are the downstream targets of that? And as you can see, we've got all of the downstream markers well recognized for basal cell carcinoma, all in this population. And indeed, we've got CD200 positive cells, both in the basal cell carcinoma as subpopulation within the endothelial cells. And then we can ask the question, back to the original hypothesis, is BCC something that differentiates? And if we look at a well-established late differentiation markers such as filaggrin. We see that that's evident within the unsorted basal cell carcinoma. But now if we look at the sorted CD200 population out of basal cell carcinoma and single cell sequenced, we see that it's negative and there's no differentiation within there. But what is there is P63, which is a gene that is involved in stem cell proliferation. So again, suggesting that within that CD200 population, it behaves and looks very much like a stem cell. Anyway, that's our foray into single cell sequencing. What then became the next hypothesis is, well, if you think that the bulk of the BCC is all differentiated, and the only driver population for the growth of the tumor is that small CD200 population, then clearly the only population that matters in terms of immune evasion is the CD200 population. The rest of it can die away, but the driver is all in the CD200 population. And so we asked the question of, does this do any immune evasion? And we compared it to SEC, in which both we've shown that they have a different cancer stem cell marker, and we know that within SEC there is PD-1 antagonists that are used, whereas in BCC they don't seem to be used. What we find is that in both SCC and BCC, CD45 immune cell numbers are fairly similar. 15% of the cells within that whole tumor tissue area are immune cells going after the tumor, and yet you have the tumor continuing to grow. What we couldn't find in the BCC, and may explain why we don't find efficacy with PD-1 checkpoint inhibitors in basal cell carcinoma, the clinical studies have been done, is that we couldn't see any evidence either in the unsorted or in, more importantly, the sorted population of PD-1 checkpoint markers. So we then hunted to see if there are any differences in the immune cells surrounding squamous cell carcinoma and basal cell carcinoma. And although there are lots of panels, let me drag your attention to this panel, because otherwise it's fairly non-different, well, there's no differences. And in this panel, these are the NK cells around around normal skin, squamous cell carcinoma, and basal cell carcinoma. When we quantified them, we could see NK cells around in normal skin in squamous cell carcinoma, but they're almost zero around basal cell carcinoma. And we've gone a little bit further. So this is the circulating levels of NK cells, and they're marked with CD56, and they're negative for the T cell marker CD3. So you can see 7% in this example. And what you find is that there is no natural migration of immune cells from the blood to the tumor. You find a complete loss of NK cells in and around basal cell carcinoma. And these are matched samples. And what you can see is that even though the patient has lots of blood, NK cells in their blood, in the tumor, you almost block off and don't have any of those cells. Which then asks the question of, well, is CD200 relevant towards NK cells and their ability or their lack of presence in the tumor microenvironment? And to do these experiments, we needed some positives and negatives to do some tissue culture and stuff. So what we found were two NK cell populations, NKLs, NK92MIs, and whilst NK92MI, the red one, has CD200 expression, we have no CD200 expression in the NKLs. And so we could say there are NK negative cells and NK positive cells. These are CD200 receptor positive, CD200 receptor negative. And if we put CD200, which should bind its receptor on those cells, and then switch off the MAP kinase pathway, of course, which we know from melanoma, you should find a reduction in phospho-ERK. And we see that with the positive cells, which have the CD200 receptor. We see a reduction in phospho-ERK, whereas we don't see a reduction in phospho-ERK with the negative cells, suggesting that they're functionally relevant as well as not having the receptors. So we now have NK cells that are positive and negative for the receptor. The next thing to do would be to create tumor cells that are positive for CD200 and not expressing CD200. And to do this, we used a lentiviral vector, and so our HeLa cells here, although we've done BCC cells, and you'll see some data on that, don't express CD200, and then we can put in the empty vector so that we just have GFP, but no CD200, and we could select out a population where we've put a vector with CD200, and so you've got CD200 positive and a GFP positive. GFP becomes important as we go along. And then you can ask the question of, well, now if I incubate the positive and negative tumor cell with an NK cell, do I see the NK cell having, what happens to that phosphorylation of ERK and its activation signal? And as you can see, if your tumor has no CD200, and if your tumor has positive for CD200, and when it's cultured with the NK cells, the CD200 positive tumors have less NK cells that are activated with this phospho-ERK. Okay, so that's one level. The next level would be to say, well, okay, do the NK cells secrete gamma interferon? That's what kills the tumor cells. That's one of the ways in which it does it. It will release gamma interferon when you co-culture. And so here we've got the HeLa cells, and so we've got NK positive cells only, and those are the gamma interferon dots on this LE spot. And then when you co-culture with HeLa cells that are positive, you found that many dots, which are not too dissimilar to just the NK cells alone. But if you had the negative tumor, the tumor that doesn't have this suppressive CD200 on the surface, then you find that the NK cells are very active at wanting to kill it off and releasing gamma interferon. And then you've got some controls at the bottom, so you could put in a negative cell, and this time add in a CD200 peptide. So you circulate CD200 around in the pool of that culture cell, and it kind of suppresses it back down from there. Or you could put in an antibody that blocks the CD200 binding to its receptor on the NK cell, and then you find that actually you're killing more than you did if you didn't have that antibody in. So clearly CD200 was stopping NK cells from releasing gamma interferon. But NK cells, the great muggers of the world, go around circulating and grabbing and killing cells. And what you see here is, don't forget, we've got the green HeLa cells, these are the tumor cells, and this is a HeLa negative, so CD200, there is no CD200, and we put a positive NK cell, and what happens is the NK cell comes in and then kills the HeLa cell, which is green, and turns it red. Red is where it apoptoses. And what you can see is that if you look over time, your HeLa negatives die off, but your HeLa positives carry on surviving and growing. And you could do the reverse experiment, which is just put in your HeLa positives, and then if you put the blocking antibody again, you can get killing again, suggesting that this signaling pathway between NK cells and your tumor cell with or without CD200 is very important. Okay, so then you take the tumor, you put it into a mouse, poor mouse, and what you ask is how much infiltrate and cellularity of tumor there is, and then the area of necrosis, what happens in terms of the tumor if you put this tumor in. What you find is that with your HeLa negative, there's a lot of infiltrate, more than there is in the HeLa positive, suggesting that even in the in vivo situation, the CD200 is stopping NK cells from coming in and killing. You've got tumor cellularity, as in your number of tumor cells hanging around, is higher in the HeLa positive, that's a tumor with a CD200, and then here you have less dead tissue within the tumor if you have CD200 positive. And what was interesting, and I think the reason why we were successful in terms of our publication, was when we did the reverse experiment with our cells. So here we have tumor cells again in green, if you remember, but this time these are the cells that express the CD200, so these are the HeLa positives. Now watch which cell dies. It's no longer the tumor cell, because the tumor cell now divides gradually as it's living there happily, But actually the cell that dies is the NK cell that comes in trying to kill the tumor cell. So not only am I now talking about inactivation of NK cells, but I'm actually talking about death of NK cells. And if we then measure it over time, as Elise had done, what you find is that up to 25% over 24 hours of NK cells are killed by the tumor expressing CD200. They weren't killed, if you remember, by the tumor that wasn't expressing CD200, only by the tumor that is expressing CD200, and leave alone the fact that the tumor cells themselves stay happy and divide away. Okay, long story short, there's lots and lots of experiments in this pathway that we've now established. So the pathway, we already talked about CD200 binding its receptor, switching off the MAP kinase pathway. What we then subsequently found was that the MAP kinase pathway is a regulator of this thing called PPAR gamma, which we all know because of diabetes and all the pioglitazone drugs. And what happens is that if you have increased translocation of PPAR gamma, that creates death receptors that are then produced by your in your NK cell, and then once they're up on the surface, that's what leads to apoptosis. And the death receptors are what's the driving pathway. So there's, like I said, there's a lot of experiments, and I didn't want to bore you with all of the plots, but, and you can always read about it, but the fact of the matter is we've established a pathway that occurs with NK apoptosis. And you can do the experiment. So if you put in, these are NK positive cells, and if you put in your CD200 peptide, you can see that you get an increase in FAS, FAS ligand, and FAD-I, all of the components of the death receptor and its ligand to cause the death. If you put in an inhibitor of just ERK, which is that pathway where we said if you bind with CD200, you switch off ERK. So now if you just switch off ERK, you still see these genes going up. And if you put in your PPAR gamma inhibitor, you find these all go down. So then the next question became, well, what happens in BCC? Do we find that there's a loss of NK cells? Yes, we've done that already. What about loss of active cells based on CD200 expression? So if we go to Tony Oro's database of transcriptomics, and we then analyze that series for CD200 expression, we can subdivide it based on CD200 high and low. So this is the high group, which is twofold higher CD200 versus the low group, and we find that these activation markers for NK cells are all down in that population. And there's a small cohort in that, because there are no big human genome studies in terms of basal cell carcinoma. If you look at the smaller series of resistant BCC versus sensitive BCC, we see the same phenotype, a higher level of CD200 and a loss of all of the active killer activation markers on NK cells. Okay, so we've now established that CD200, kind of important at reducing activity of NK cells and also leading to NK cell death. But I also told you that CD200 was only on 2 to 3% of the BCC cells. How on earth was it getting rid of all of the CD200 around the whole tumor? Or how was it getting rid of all of the NK cells around the whole tumor if it's just fixed to that small population? And the answer is ectodomain shedding. So this is the secreted CD200 in BCC versus normal skin. It's slightly higher, bearing in mind it's only in a small population of BCC. And what we looked at when we did our transcriptomic profiles were MMP7 and 11 were elevated in BCC. And as the subsequent slide shows, if you add in MMP3, you shoot up CD200, shedding from the surface that leaves it soluble around to wash around the tumor and therefore do its actions. They're still active when they're solubilized. And similarly with MMP11, and these are inhibited by the tissue inhibitor of metalloproteinases 3. So back to BCC. BCC in culture, which we once showed as in a way of studying BCC, you get small round colonies. If you put an idiopathic antibody in, you get nothing, and the colonies are happy. If you put CD200 and blocking antibody with your NK cell co-culture, you get death of your BCC. Do it in vivo. If you take your BCC, CD200 negative and positive tumors, and now you have your tumor numbers, you find that your CD200 positive tumors are slightly bigger and have more cells and have a reduced amount of necrosis, have a lower immune infiltrate, and have a reduced number of NK cells around the environment. Which then takes you to the next experiment, hopefully he says, which is to say, well, what happens if you put the blocking antibody in? As in, can you switch off signaling in vivo? And so here we have the experiment. So this is negative tumor with the blocking antibody as control, but actually it's the positive tumor we want with the blocking antibody. And what you find is that with the negative, you get that level of killing. And now with the blocking antibody, you get, this is tumor cells. You have high tumor cells if you have your CD200 positive cells. And then if you put the blocking antibody, you drop it. If you, in terms of the immune cells, you start off with a low number, and then they go up if you put the blocking antibody in. And likewise, in terms of areas of necrosis, it's lower, and then if you put the blocking antibody, it goes up. Is it relevant to anything else? So we looked at the precog database. This is now something in the order of 20,000 transcriptomic profiles of multiple different tumor types. And what we did was we correlated your outcome score from CD200 expression and your outcome score for activated NK cells in this panel and inactivated NK cells from that panel. We looked at all of the other immune cell phenotypes, and only the NK and CD200 things correlated. And as you can see, for a number of tumors, certainly in blood, AML, ALL, BCL, high CD200 scores poor outcomes were associated with poor outcomes with activated NK cells. So there seems to be correlation and relevance across a number of tumor types. So what have I talked about? BCCs exhibit a novel immune evasion mechanism. BCC growth, which we'd previously shown, is dependent on a small subpopulation of CD200 positive cancer stem cells, and whilst the majority of cells in BCC actually demonstrate hair follicle differentiation. Despite the huge mutational burden in BCC and the brisk immune response, there were no NK cells, and we kind of worked out why BCCs don't express immune checkpoints, and that CD200 targets the NK cells, and that blocking CD200 restores the ability of NK cells to kill BCC. And with that, and my group and our funders, thank you.
Good, thank you very much. I'm afraid we haven't got time for questions. I am sorry. We are going to have to move on to our final talk of the day. Girish, sorry, my apologies. We do need to present you with your cup. I am sorry about that.
Hello, my name is Dr.
So we'll just hold that last presentation, which, as you can see, is going to be virtual. Well done, Girish. Thank you. So our final presentation is from Professor Susan Taylor, who's a professor of dermatology at the University of Pennsylvania. She's done pioneering work in establishing skin of colour as a subspecialty in dermatology, and that's reflected in many of her key clinical interests. And today she's going to talk to us about genetic, biological and structural differences in skin of colour.
Hello, my name is Dr. Susan Taylor. I'm the Burnett Johnson Endowed Professor of Dermatology at the University of Pennsylvania. It's my pleasure to discuss with you today variations in genetics, biology, and the phenotype of cutaneous disorders in patients of color. I have no relevant disclosures for this talk. So our objectives today are to address the knowledge gaps in the literature regarding the pathogenesis and interplay of genetics and biological factors of several common diseases in skin of color patients. And those include atopic dermatitis, psoriasis, and hidradenitis suppurativa. We'll address how structural, physiological, molecular, and genetic differences among various racial groups may contribute to differences in the disease phenotype and outcomes. So let's start with atopic dermatitis. We know that the disease burden of atopic dermatitis is disproportionately increased among skin of color patients compared to white patients. In fact, Asian and Pacific Islanders are 7 times more likely than whites to be diagnosed with atopic dermatitis at a derm office visit. Black children are twice as likely to develop atopic derm compared to white children after controlling for socioeconomic factors. Now, there are variations in the morphologic presentation and color of atopic dermatitis lesions that occur more frequently in our skin of color patients. So let's start with the follicular morphology, which we see more commonly in our Black patients as compared to our white patients. In this type of morphology, there's follicular prominence, and this may be the only sign of atopic dermatitis in this population. We find it very helpful if you palpate the skin with your eyes closed using your fingertips, and this can help you assess the flare of disease when the follicular morphology is the only morphology present. There can be variations in the color of the papules, so the follicular-based papules, and they can be erythematous, violaceous, gray, brown, or hypopigmented. Now, the papular morphology can have follicular accentuation. It occurs commonly on the trunk and the extremities, and the papules can range in color from red to violaceous. They could also be hyper or hypopigmented. And again, you can use that tool of your fingers to palpate these particular papules, and it can provide a clue to if there's a flare of the disease. There's a lichen planus-like morphology that occurs more commonly in our skin of color patients, and you can distinguish it from true lichen planus in that the papules are round rather than polygonal. The lesions often occur on the extensor surfaces of the body, and it's been written that there's rapid response to topical steroids. Here we have a prurigo-like nodules that can occur in our skin of color patients, and even keloidal prurigo, which occurs more commonly in Black patients, particularly those with chronic atopic dermatitis. Now, our lichenified morphology, many of us are very familiar with it. It occurs more often in Black and Asian patients, again, with chronic atopic dermatitis, and they can present with these lichenified red, brown, violaceous, or gray plaques with accentuation of the skin lines. The psoriasiform morphology is more common in our Asian patients, the psoriasiform morphology can be very well demarcated with increased scaling. The color of the lesions can vary, where in patients with skin types 1, 2, and 3, the lesions appear erythematous, whereas those with 4, 5, and 6 skin types are lesions of atopic dermatitis or more violaceous or brown. And the erythema can be easily missed on clinical examination. Now, when present, as I said, the erythema can be easily missed, and we can see on this arm of an individual with darker skin tones, we can definitely see some erythema, but I would submit that there's probably subclinical erythema on most of this area. Now, if you cannot appreciate the erythema in patients with atopic dermatitis, that often means our easy severity score and other scoring systems can be underestimated in these particular patient populations. Also, there can be a difference in the location of the atopic dermatitis in our skin of color patients. Black patients often present with more extensor and truncal involvement as compared to white patients. Now, let's look at some of the genetics. Now, we know that filaggrin genes have been extensively studied in atopic dermatitis, and loss of function mutations in filaggrin have been shown to differ among different racial ethnic groups. White children with atopic dermatitis were over 2 times more likely of having a filaggrin loss of function mutation as compared to Black children. And this, of course, mutation can lead to impaired barrier function in individuals with atopic dermatitis. And it's hypothesized that filaggrin mutations are less common in Blacks because filaggrin degradation products serve as substrates for uracanic acid, and that's an ultraviolet absorbing substance in the stratum corneum. So a loss of function mutation in filaggrin may result in less protection from ultraviolet radiation. And this decreased mutation in Blacks may serve as protection from UV radiation in Black skin. Now, instead of loss of function, filaggrin mutations common in whites and Asians with atopic dermatitis, mutations in filaggrin 2 genes have been found in Blacks with atopic dermatitis. And filaggrin 2 is another gene that plays a role in skin barrier function. Decreased expression of filaggrin 2 is associated with lesional skin in atopic dermatitis and a thinner epidermis. Now, studies have identified mutations in Latinx and Hispanic individuals with atopic dermatitis, that any mutations in that particular group is lacking in the literature. However, a study of Chilean adults with and without atopic dermatitis demonstrated that filaggrin variants were present in about 15% of those with severe atopic dermatitis and 7% with mild to moderate atopic dermatitis. Now, unfortunately, this difference did not reach statistical significance, perhaps because the study was underpowered, but it does suggest some filaggrin mutations in this Hispanic Latin population. Now, in regard to our Asian populations, they looked at those with atopic dermatitis, particularly in the Korean, Japanese, and Chinese populations, and they noticed that they had higher IgE and Th17 levels. So Asians with atopic dermatitis may also produce, it's been demonstrated, more IL-17. And we know that this is seen in psoriasis. And we know that Asian patients with atopic dermatitis have a more psoriasiform appearing presentation. So that's pretty interesting. In contrast, there was no increase in IL-17 among whites with atopic dermatitis. Now, in a study of 10 Black individuals with atopic derm, there was upregulation of IL-36 in lesional and non-lesional tissue. Now, this upregulation of IL-36 may contribute to the lichenified lesions seen in some Black individuals with atopic derm. In a cohort of about 21 Asian individuals with moderate to severe atopic dermatitis, Th17 was upregulated. And upregulation of Th17 and Th22 and their associated cytokines may contribute to lichenification and hyperkeratotic lesions that we see in atopic dermatitis in some Asian populations. Now, we know that there are some structural differences that have been described in Black patients, and Black skin is considered to have a lower ratio of ceramides and cholesterols in the stratum corneum, and this may contribute to the increased disease severity that has been observed in this population. Some studies have shown that Black skin have higher transepidermal water loss, and this could contribute to impaired barrier function and, again, increased severity in atopic dermatitis in this particular Black population. So higher transepidermal water loss may result in lower skin hydration and xerosis, a hallmark of atopic dermatitis. Now, I want to point out that there are reports of transepidermal water loss differences that conflict in the literature. Some that show higher transepidermal water loss in Blacks and some lower. So more work needs to be done. So in summary, we know that in Asian patients and Hispanic and Latinx patients, there's a loss of function of the filaggrin gene, and that might be responsible for the impaired barrier function and persistent atopic dermatitis. This is in contrast to a mutation in filaggrin 2 in the Black population. There is upregulation of Th17 and 22, and there are associated cytokines in Asian populations and some Black populations, an increase in IL-36. Now let's move on to psoriasis in skin of color. In this disorder, there are, again, differences in morphology. I want to point out that there's a higher prevalence of psoriasis in white patients as compared to Black or Hispanic patients. However, psoriasis may be of increased severity in Black patients, and it can have a greater psychological impact on those Black patients. Inflammation that manifests as pink or red lesions in lighter skin, in contrast, is violaceous or dark brown or even gray in individuals with darker skin tone. Again, an inability to appreciate erythema can mean that PASI scores are underestimated in type 4, 5, and 6 skin. Now, plaque psoriasis is by far the most common type of psoriasis across all racial groups. However, there are some differences in morphology and plaques in Blacks in that those plaques tend to be thicker, scalier, and there's more extensive disease involvement. Also, compared to white patients, Black patients may experience a higher degree of dyspigmentation, and that arrow points to areas of post-inflammatory hyperpigmentation. In our Asian populations, there is small plaque psoriasis that has been described. This is a phenotype that's distinct from gut-tape psoriasis. And also, Asian patients may also present more often with erythrodermic and pustular psoriasis as compared to white patients. A study of 37 Asian individuals with biopsy-confirmed psoriasis and those with small plaque psoriasis lesions were more likely to have higher levels of IL-17A when compared to Western individuals, white individuals with large plaque psoriasis. And in a 2022 systemic review and meta-analysis, they found that there was no differences in the efficacy of IL-17 inhibitors for psoriasis between white and Asian populations. Interesting finding. Now, the allele HLA-CW6 is associated with increased susceptibility for psoriasis in skin of color patients, particularly those from Korean backgrounds, Pakistani, Turkish, and East Indian backgrounds. Now, despite having a higher prevalence of, again, HLA-CW6 in Blacks, the rate of psoriasis in those individuals is actually lower compared to whites. So that would suggest that perhaps another gene contributes to the increased susceptibility of developing psoriasis in this Black population. HLA-CW1 is associated with pustular and erythrodermic psoriasis. It's also been associated with increased prevalence of psoriatic disease and increased severity of psoriasis in those of Chinese, Thai, Japanese, Turkish, Kuwaiti, and Pakistani descent. There's no association, however, between HLA-CW1 and psoriasis in white individuals. So there are some differences in morphology as well as in the genetics between Asian and Black populations and white populations. So in regard to hidradenitis suppurativa in skin of color patients, there are some variations between different racial ethnic groups. We know that HS is due to hyperkeratinization of the epithelium of the follicular infundibulum, and this leads to a keratin plug that dilates the follicle and causes rupture. Then the follicular contents, including sebum and keratin and various microbacterial organisms, extrude into the dermis, and it results in a immune response that is rather sustained. We know there's a higher prevalence of HS in African American populations, 2 to 3 times higher as compared to white patients. And we also know that the disease is more severe in our African American population. Now, HS typically affects intertriginous areas, but it has been pointed out that in Koreans and Japanese patients, it more commonly affects the buttock area. We know keloidal scarring, particularly in our Black, Asian, and Hispanic patients with HS. Now, there are some differences in genes. We know the genetic profile of HS in East Asian populations have been studied quite extensively, and they've identified mutations in the subunit of gamma secretase. And that has been reported in these East Asian populations. So overall, the prevalence of gamma secretase mutations is lower in whites with HS as compared to East Asians. Now, these mutations result in impaired signaling of the Notch pathway. In a cohort of whites with HS, Notch signaling was elevated. And in contrast, Notch signaling was attenuated or lowered in Chinese individuals with HS. Now, there's a report of a Black family with HS, and there was a nonsense mutation in one of the gamma secretase genes that was detected. And it was also determined that it was inherited in an autosomal dominant manner. Now, a frame shift and nonsense mutation, again, in one of the 4 subunits of the gamma secretase gene was detected in 2 large unrelated East Indian families with HS. Now, biologics have been used in HS with success, and it targets elevated levels of cytokines such as TNF-alpha. And elucidation of dysregulated cytokine expressions in skin of color patients is much needed, and that could help to reveal possible new targets for biologics. Now, Blacks with HS had lower levels of cytokine levels to TNF-alpha, IL-22, 23, 17F, and IL-10 when compared to other races with HS. So it's unknown if lower cytokine levels in Blacks with HS impacts their responsiveness to treatment. So it's also hypothesized that the pathogenesis of HS, which involves follicular hyperkeratosis and subsequent occlusion, may occur more often in Blacks because one study indicated that Blacks had larger, more numerous, and more productive apocrine glands. So this could partially explain the prevalence and severity of HS in Black people. However, that particular study was done with a very small sample size, so it needs to be repeated before we can really hang our hats on that data. So in regard to hidradenitis suppurativa, in Blacks, there were 2 studies. The Black individuals were found to have larger, more numerous, more productive apocrine glands, and that could explain their propensity for HS. We know that gamma secretase gene mutations have been implicated, particularly in our Asian population. And we know that in a small study of Black individuals, there were lower cytokine levels. So we need to investigate that further. So in this last 20 minutes, we were able to discuss the genetic, immunological, molecular, and structural differences in several inflammatory cutaneous disorders, including atopic derm, psoriasis, and HS. We actually got to see that the lack of genetic studies in skin of color patients really stresses the importance of basic science studies in these particular populations for these very important and frequently occurring disorders. So with that, I want to thank you for your time and your attention.
So Professor Taylor, I don't think is able to join us for a Q&A, so that finishes the Professor and Registrar Symposium. Thank you for all coming, and congratulations to all of our fantastic presenters this morning.
consultant dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm
Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of color dermatologist. Thank you.
My name is Ure Eke and I'm a consultant dermatologist, a Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of color dermatology is of particular importance to me. Obviously, I'm a man of color myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amarful and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Royal Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London. Diversity to me means working with those from different ethnic racial backgrounds with one common goal.
Hi, my name is Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Consultant dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane, and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months, and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population, and that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name's Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke, and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of color dermatology is of particular importance to me. Obviously, I'm a man of color myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Marful, and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London, diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. As you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting. Pugh Banerjee, consultant dermatologist. I founded the Skin Diversity Subcommittee at the BAD in April 2020. I am passionate about making change in UK dermatology for our patients, for dermatologists, for everyone. This year, as the Clinical Vice President of the BAD, I am the organising chair of the annual meeting. I have invited more diverse speakers and more diverse topics than we've ever had before. On the 5th of July, I'm launching the Ethnic Diversity and Identity Symposium. This year, to celebrate BAD Diversity 2022, the Skin Diversity Subcommittee and I invited BAD members from different cultural and ethnic backgrounds to share their own video clips to tell us who they are and why they feel diversity is important to them and to UK dermatology.
My name is Dr. Rosemary Akimisane, and I'm a specialty doctor working in Basildon Hospital. I've been working in dermatology for 18 months, and I'm excited to have joined this specialty at a time of innovation regarding skin of colour. This is important to me because as patients we strive to provide optimal patient care, and an integral part of this is having confidence in recognising and diagnosing skin conditions of all skin types.
Hello, I'm Anshu Sahota. I'm a consultant dermatologist working for the past 22 years at Barts Health in London, including Whipps Cross Hospital, and I have an interest in surgical dermatology and all aspects of dermatology, including nail and hair disease. I work in a very culturally and racially diverse part of London, and I think the NHS staff who look after patients should reflect their population. And that's why I think diversity is important.
Hi, I am Archana Rao. I am a consultant dermatologist and I have trained and work in London. Previous to that, I have trained in dermatology in Mumbai. I think diversity is key to our society, as our strength lies in our differences, not our similarities.
Hello everyone, I'm Dimple Jain. I work as a consultant dermatologist in Royal Shrewsbury and Telford Hospital in Shrewsbury. I completed my dermatology training in lovely Northeast region and moved to Shrewsbury for family reason. I've been working in dermatology for more than 15 years now, with initial 3 years in India and been working in UK for the last 12 years. In relation to my ethnic background, I always felt loved, supported and respected by colleagues and patients. I believe and follow the principle of unity in diversity. Thank you.
My name is Wal Hussain. I'm a consultant Mohs surgeon here in Leeds. I've been here for 11 years. I love my job. I'm a devout practicing Muslim. I pray 5 times a day, and I'm grateful that I've just completed the month of Ramadan.
Hi, I'm Dr. Marissa Taylor. I'm a consultant dermatologist in the Greater London area, and I look forward to seeing you at the BAD 2022 in Glasgow.
My name is Dr. Mary Summerlad. I am a consultant dermatologist. I live and work in London. I did my dermatology training in the Royal London and Royal Free rotations starting back in 2012. I think having an ethnically diverse dermatology workforce benefits not only our patients but ourselves as a workforce. It helps us have diverse ideas and support innovation and improvement in services.
Hi, hello everyone. My name is Suan Chan. I work at the Birmingham Skin Centre and I'm a skin of colour dermatologist. Thank you.
My name is Ure Eke, and I'm a consultant dermatologist and Mohs micrographic surgeon working in the West Midlands area. I completed my dermatology training in 2013 and subsequently completed my fellowship in Mohs surgery in 2015. Diversity is a wonderful opportunity that can bring people of different backgrounds and cultures together to inform and enrich our practice, but not just in dermatology, but other aspects of life.
Hello, my name is Ahmed Kazmi and I'm a recently qualified dermatologist. I did my training mostly at the Royal London Hospital and I'm currently on sabbatical in Australia doing a fellowship in hair disorders and alopecia. And skin of colour dermatology is of particular importance to me. Obviously, I'm a man of colour myself, but I feel historically it's been an area that's been neglected, and we've tended to see dermatology and dermatological pathology through a white skin lens and just that perspective alone. And it's great to see that times are changing and that patients are starting to benefit from that wider, more inclusive approach to dermatology. Thanks.
My name is Dr. Emma Amwafo, and I'm a dermatology registrar working in London. I've been working in dermatology for about 2 years now. I believe we should all acknowledge and appreciate difference within society, especially within medicine. It's super important we all take steps to understand diversity and how it affects the world we live in.
Hi, I'm Mia Jingao. I'm a consultant dermatologist working at Royal Free in London. To me, diversity is about recognizing everyone's different and the value those differences bring.
From London, diversity to me means working with those with different ethnic racial backgrounds with one common goal.
Hi, my name's Dr. Manuel Lamptey. I've been a doctor for the last 5 years, but I've been working with the dermatology team at King's the past couple of months. Diversity to me means embracing different cultures.
Hello, I'm Emilia Duarte Williamson, consultant dermatologist. I've been a dermatologist for more than 20 years and worked in many places around the country, but have been in King's for the last 3 years. as you can clearly see, the dermatology team at King's reflects the diversity of the population we serve, which is South London and even the London population. Thank you.
I hope you enjoy the annual meeting.
This is the last plenary, isn't it? Yeah, it's gonna. There's just some more people coming in. Oh, there we go.
Yeah, I just texted.
Here she is. Thank you. We had a little panic.
Yeah.
Cheers. So that's for Ruth. Thanks so much, Sally-Ann. Thank you. That was well remembered. Right, just a couple more people coming in, and then I will started. Is Chris just there? So welcome everybody to the last plenary session of the 102nd BAD annual meeting in Glasgow. It's been an absolute pleasure to be here with you all. And I'm delighted to be co-chairing this session with Mabs Chowdhury. Our first speaker needs very little introduction. Is Carolyn Charman, who's a consultant at Royal Devon and Exeter Hospital, and she's also the clinical advisor for NHS Transformation Directorate. So thank you very much, Carolyn. Over to you.
Thank you, Tanya. And it's lovely to see you all sticking out to the end here. So I'm going to just take you through, hopefully, if this works, an overview of teledermatology, which has obviously changed absolutely massively since we all met face to face. And I'm really going to try and focus on bringing us back to the patient and equality of access for patients through teledermatology, and then a kind of overview of what's going on nationally, and then applying that to your local organisations. So I was really struck, I don't know how many of you were in the session that Tess McPherson did. There was a youth panel, and one of the young girls with eczema did this quote that I put in purple. But I think, this is what we're facing at the moment, and this is so typical of the length of time that patients are waiting through traditional pathways. And so let's keep, all the way through this talk, our mind on how, a lot of this is going to be about how we can speed people through pathways and how we can pull out that proportion of patients where we can either give them interim advice or we can manage them much more effectively or as effectively, sometimes without them needing a face-to-face review. So I'm going to talk a little bit about advice and guidance, which has been the main explosion during the pandemic, and a shift across not just dermatology, but across so many specialties to doing what we can right at the beginning of the patient journey, and that's usually with a consultant and GP interaction. And so a cultural shift away from a post a referral and see that patient several months, weeks or months later. We've obviously seen huge advances in both NHS and commercial platforms to help telemedicine in general. We've seen a rollout of image apps, etc. We've also, I think all of us will have seen a widening of the workforce, particularly in primary care. So many of us will be receiving referrals from advanced nurse practitioners or other workforce to support the GPs. And so we are all very mindful of keeping the thresholds for referral and not drowning, but also using telemedicine as an educational tool for that. We've got a new 2-week wait pathway that gives some flexibility when receiving images taken by GPs, and obviously teledermatology is a platform for artificial intelligence. So, ironically, a week ago, this planned sort of digital transformation was released with a forward by the then Health Secretary, and we're obviously in quite a lot of transition, so keeping up to date with what's going on in the Houses of Parliament is almost as difficult as keeping up to date with the pace of teledermatology. But the focus of this, for us all, there's much that is relevant, because there's a lot of focus on using the NHS app, which obviously was launched in 2019, but now has a huge number of people signed up, and also levelling up the inequity of access to the electronic patient records in trusts, so that you can use your own phone to take photos, etc. in clinic, and use that particularly for in-hospital teledermatology. And there's also a little bit in there about AI in dermatology. So I think in a lot of documents, there's a lot of focus on dermatology NHS planning documents and political documents. And also for the first time, we've got teledermatology in the curriculum and in the manual, the essentials manual that accompanies it. So I think I'm sure we're all doing teledermatology to some extent, but we now owe it to our trainees. We can obviously supplement that with the annual teledermatology skills course, which is coming up on the 3rd of November, which David de Burker and Beth Wright have run for some time. To keep up to date, then everything is on the clinical services section of the BAD website, and obviously this talk is all on behalf of the clinical services and the teledermatology subcommittee who have worked so hard to keep all the resources up to date as things change. And there's also obviously an AI section on the clinical services website as well, which really aims to be that sort of single source of truth, as many of us are approached by AI or through our commissioners and chief executives, etc. So just keeping that safe, but also allowing it to help and to blossom, but in a safe environment. And then I think if we just try and orientate where teledermatology is used, it's used in all sorts of areas, obviously in hospital and pre-referral. The main change where I've circled has been between GPs or other primary care referrers and dermatologists. And a lot of this is about trying to take the pressure off the 2-week wait pathway by using what we now have as an enhanced advice and guidance channel, certainly in England, and pushing more patients through advice and guidance, but for a good reason, not for targets or anything else other than clinical benefit to those patients to reach them more clearly, more quickly. The graph for expansion of advice and guidance in dermatology is going up. Now, I don't think this is going up still because of the lowering threshold. What we're now seeing is many services are switching off other channels in, and they're using advice and guidance for a single route in for non-2-week wait referrals, which has pros and cons, but seems to be the direction of travel, and there will be something in the BAD newsletter about that. So the graph I show you is from the e-referral service, which is the sort of standard core channel that you can use, all accessible to all people in England. There are also a number of very good platforms like Synapsis, who are demonstrating here, Consultant Connect, who have the added benefit of being able to do advice and guidance from your mobile phone, and often linked into phone advice and guidance as well. So the ERS platform, it looks like this, and now there's an authorization for the GPs to tick if they are allowing you to convert the advice and guidance directly to a referral. But very importantly, you can still give information back at the same time if you do convert an advice and guidance to referral, which is not something that we've had previously in existing channels. So you can look on the advice and guidance toolkit for that. I think it's helpful to look at other specialties as well, because when you're redesigning services, often this is a whole sort of system-wide approach. And this is the increase in ERS advice and guidance from the start of the pandemic to March. I've chosen because it's a useful comparison. So we can see that our advice and guidance has gone up over 400% in this short time. But over many specialties, there's been an increase in over 100%. I mean, commercially, this is exciting data, isn't it, if it was, but I mean, NHS data is incredibly exciting for how we're reaching our patients, but you can see why the number of platforms is also exploding. And I think in other specialties as well, as I say, there's been a shift away from the concept of a GP having a conversation which says that they're going to refer a patient, and it's now towards a dialogue which says, I'm going to seek specialist input. One of the outcomes might be that we manage you with advice, with the support of the specialist. And one might be that you go straight to test, potentially straight to surgery with a phone call, or that you're converted to an appointment of hopefully to see the right person in the right place at the right time, maybe with video or phone if more appropriate. But very importantly, we're bringing the GP into this decision making, because this is not a rejected referral when we use this channel. The GP has the last say and they close the dialogue. So I think most people here will be experiencing a growth in 2-week wait referrals that is probably impacting on patients with inflammatory disease, like the patients with eczema that we've seen. And so, again, the push is to, if possible, encourage GPs to use this advice and guidance channel and maintain a rapid turnaround of ideally 2 days, which is potentially difficult in some units, but the model access policy actually says we should all be vetting our normal referrals within 2 days as well. But this is down to local turnaround agreement, and many places extend that out. And we'll all have seen many more photos coming directly from patients who are able to send their photos to their GP through a secure platform, usually called eConsult or AccuRx. And those are variable quality, and they obviously won't usually have dermoscopic images, although I'm sure Johnny Bowling will tell us about patient dermoscopy. It may become a thing of the future, and it is possible. So the advice and guidance channel is by choice being used as a referral channel now, and this is the data across all specialties, just showing that the number of advice and guidance that GPs are authorising is just steadily climbing. So there's now sort of 3/4 are authorised, but interestingly the conversion rate remains the same, and this is the same sort of figures that we see in all specialties. So if you have everything coming through advice and guidance, this will probably level out usually at around 50%. So there are still many more patients that we could be managing. And obviously you need to keep an eye on how many of those eventually come through, but it's usually very low. So these are the number nationally of ERS advice and guidance requests that as a specialty we are converting, but this is generally where it's running alongside a referral service, so you may have less severe patients. And so I think we're all aware of where we can add value. So there are, certainly in our unit, many of our patch test patients now have come through an A&G route. The patient with the hands there was a beautician and had acrylate allergy on patch testing, but the point is we could pick that up. We could advise on avoidance, we could start the right treatment through the A&G, and then when they came to the patch test clinic, they're all ready. We had a phone call first. And the others, I think, are all self-explanatory. I think particularly for eczema, we can do so much for our patients by giving some interim advice. And for low-risk, non-2-week weight lesions, this will be down to departmental policy, and many of us will have community services, but redirecting, educating, which I think is one of the most important things when a GP consultant relationship or the wider workforce is turning around within 2 or 3 days. Your educational value of case-based teaching is really huge, and the GPs love it, but there are resource implications as well. I think you probably have all seen the 2-week weight skin cancer pathway. Basically, it allows now GP images to be used by consultants to stop the clock without seeing the patient, but a phone call is still required to meet the legalities of the 2-week weight pathway in terms of having a direct link with a person in the team. This will be replaced by the faster diagnosis standard, which will be clinical diagnosis within 4 weeks, not a histological in most cases. And so those are all there through the BAD website if you haven't seen them. So for our 2-week weight pathway, ideally, I guess what we need to do is encourage as many photos to be coming through via A&G with these lesions like hemangiomas and seborrheic keratoses. If it comes to A&G, you can return it without dermoscopy, but obviously we've all got safety levels that we need to comply with. But it just gives more flexibility, and we can triage patients directly. There's a teledermatology survey that's just gone out, and Urshad Zaki and others were particularly interested in how people are approaching direct to surgery with pre-op phone calls, etc. So there'll be some more information coming on that. And then in the background, so this is obviously a collaboration, so a big jump. So our latest figures in May for dermatology are almost 16,000 A&G compared to less than 3,000 before the pandemic. So there's been obviously a lot going on in the background with collaboration, BAD, GERFT, funding of approximately 7 million across the country, mainly for dermatoscope rollout, but also for platform redesign, job planning, application program interfaces. So there's a lot going on. There's also advice and guidance is built into targets, which are across all specialties. So at the moment, there's 16 per 100 across all specialties. So, we easily fulfill that, but the point is we're not really doing this for targets, we're doing it to reach our patients. A lot of telemedicine is a cultural change, and it's a resourcing and shift of the way we work. So unsurprisingly, there's been a lot of publications, a lot of discussion, a lot of BMA meetings around the concept of rejecting more referrals or returning more referrals with advice. and where the clinical responsibility lies, where the medical legal liability lies. There's some pieces of some documents on medical legal liability about to come out and clinical responsibility, but it's basically about just communicating clearly and turning around the activity as fast as you can for your patient benefit. And I think for us in advice and guidance world, it's remembering that it's a relationship with a GP rather than the patient directly. Although as the systems evolve, I think we'll have more opportunity for where the GP is authorised to communicate advice discussions directly with the patient, but it shouldn't act as a barrier to referral. So medical photography, so there are community diagnostic centres that are springing up around the country or have sprung up. And medical photography wasn't originally built in there, but there's some work going on. Julia Schofield is helping, myself, Tanya have been involved, and we're hoping that that will be an additional hub particularly for the dermoscopy tied in with the skin cancer, for where GPs do not have the time or resources or wish to take particularly dermoscopic images. But as much as possible, I think it's helpful if we can slowly support our GP colleagues. And then I'm just going to run through a few of the apps that I'm sure you're aware of. So most healthcare professionals will be using a secure clinical image app to take photos now. So there are a variety out there. Pando is free to use for certain levels. You can use things like Consultant Connect and not commission the whole pathway, just commission the app. There are videos that Julia Schofield and Emma have produced on taking photos, both for clinicians, admin uploading, etc. They're all on the BAD website. Not surprisingly, given those figures of a 400% increase, we've seen an increase also through the commercial platforms. So we've got wonderful platforms like Synapsis, Consultant Connect, Vantage Rego. There are lots and lots of them, and we maintain a neutral stance, but they do have added extras, but over and above what ERS can deliver at the moment, although ERS is a multi-million-pound system with a lot of investment going into it. And then there are also platforms that reach directly to patients that are potentially more useful for validation of waiting lists. So Virtual Lucy by Mark Goodfield, and many of you will have had correspondence about this. And this is not just for dermatology, it's for MSK and other pathways. And these are all by dermatologists. So My Skin Selfie and My Skin Doctor are similar. So they have a commercial side to them as well as potentially an NHS side as well. And then finally, climate change. I think it's really important that we remember about the impact that our changes in how we deliver healthcare can have on the climate, and part of this delivering a net zero. And this is for staff as well as patients. I think none of us want to be doing just teledermatology. It can be quite exhausting. I'm sure we all love seeing patients, but I think, if we think about the workforce discussions that were going on in the AGM, I think teledermatology work does particularly appeal to certain areas of the workforce, particularly sometimes staff that are newly retired or recently retired and want that flexibility of delivering from home. I think the BAD stance, and for all of us, has always been to maintain integrated systems as much as possible. But I think this is the role, and interestingly, there are more applications for jobs now that are being advertised with a teledermatology component. So in summary, I think as long as we maintain these sort of core principles as the teledermatology services develop, and this is not just at the primary secondary care interface. There's obviously so much potential everywhere. I think the AI is very exciting, not just for diagnostics, but companies like Deloitte are using AI to pull out referral information, wording in letters, so that we can channel referrals to the right clinician as well. The job planning and the resourcing, particularly for GPs, is super important, and also maintaining the equity of access, particularly as we've now got several channels developing across the country, and depending on where you live or what your GP chooses, you might experience very different care. And then obviously the inequity of access to smartphones and the digital inequality. So I think I'm going to finish there. Though, thank you to the Clinical Services Unit and GERFT and BAD and NHS England for carrying out all of this work, basically. Any questions?
Thank you, Carolyn. That was a fantastic run-through of everything that's been going on in teledermatology recently. We have got time for one question, and David's over there at 3.
Hi, that was
Hi.
an excellent overview. The only bit of data missing was how acceptable this is to patients.
Yes. So patients often don't know, for advice and guidance, I mean, patients often don't necessarily know that there's an advice and guidance conversation going on. There has been lots of discussion about producing patient-facing leaflets about advice and guidance. Some of the commercial platforms like Consultant Connect have done that. I mean, I think it just speaks itself in a way that if you have a patient, you know, even within our department, if you have a patient that's going through the normal referral channel, they are going to go on to, if they're accepted, they're going to go on to a waiting list of several months, and with no facility for us to give any communication directly to that patient through the referral platform. We, of course, could phone the GP or write a letter, but that's probably not going to happen in most places, whereas if they come through an A&G arm, the digital functionality supports all of those things, so immediate advice and interim advice. There is a national A&G evaluation going on at the moment. There's already been one in primary care. There's a national one going on across 14 trusts at the moment, and that is bringing in the patient element, and it's focusing on 12 specialties, 12 high-volume specialties that I showed, but particularly on consultants' opinions and patients. So that will give useful information, hopefully.
Most of my patients with skin cancer are over 80. They barely have a smart telephone, let alone an iPhone.
Yeah.
And I just wonder how they consent to having to send something inadequately. I mean, I do think there's going to be a massive gap. I mean, we would hope that unless the patient images are high quality, that the shift will be mainly towards images being taken in the GP surgery or in the hub or in medical photography models. I mean, no clinician is ever going to accept an image to make a diagnosis if they're not happy with the quality of it. So I think the consent in the pandemic has, we've got lovely consent forms on the website in all the guidance that's already there that specifies every detail about telemedicine. But in the pandemic, there's been a real shift towards verbal consent, and with the volume and the speed that it's gone up on the back of all the GP workload, the verbal consent is what's being used mostly at the moment, but obviously we can't use any images for teaching or research without written consent. So that's another piece of work that's going on in the background to embed consent forms in to the platforms right from the start of the patient pathway.
Thank you, Carolyn. Just before you go, I've got your BAD mug.
Thank you.
Thank you very much, Carolyn. Excellent talk. So our next speaker is Jonathan Bowling, who's speaking on dermoscopy diagnosis and the dermatologist. Jonathan, I've known you at least 20, 25 years, I believe. It was really great to catch up with you the other morning. You're a consultant based in Oxford. You've been interested in dermoscopy since your registrar days, running courses. And I believe a lot of dermatologists have already taken your course by the time you started as a consultant, which is excellent news. In addition, you've published a book very recently, second edition, which looks excellent, and I'm sure that'll be an excellent resource for people to use. You're an author of that award-winning textbook, and we really look forward to what you've got to say for us in the next 20 minutes or so. Thank you.
Thank you, Mabs. Thank you. It's a real pleasure to be invited here, and it's great to actually spend the week reconnecting with colleagues from all parts of the country. So it's great to see you all. So I'm a dermatologist based in Oxford, and these are my disclosures, some of which are relevant. So the talk is about diagnosis, sustainability, surgery, and AI, and maybe how dermoscopy has influenced my practice over the last 20 years, and to reflect some of these components. So first of all, the diagnosis. We are in the home of British dermoscopy. Professor Mackey in the early 70s was actually working on describing the features that you could see. So it's 50 years since the first sort of papers on dermoscopy started happening from the UK. But then there was about a 30-year sort of gap or so. In the 90s came along, the uptake of dermoscopy was relatively stagnant. The devices were a bit clunky, having to use oil and various other media. So things didn't really change until about 2000. And 2000 was when all the planets aligned. You had now digital cameras, you had the ability to take photos, polarized endoscopy devices. So suddenly you had a resource material that you could then use to educate. So I got interested in this in the late 90s, working as in ITU in Bristol. And from there, I moved to London on a training post and organised a course with Geppi Argenziano in 2002. And the aim was to train the trainees, because during a training programme, it's very good to go through that learning curve. It's much better to actually come out of your training programme having been through the ups and downs and then have a growing competence and confidence for the rest of your training programme or rest of your career. That was the old BAD house in Fitzroy Square. So over 2003, I did a survey, and the BAD very kindly helped with the questionnaires on that. And there was a very sort of mixed pattern of who's using dermoscopy and who's not. But the main barrier was lack of education. So I started a company in 2003, and in 2004 started running courses. And this is with, again, Geppi Argenziano, Peter Sawyer. So we were able to actually get world leaders on this into actually teaching and training so that we can keep going forward with the education. That's the Medical Society of London, which is a beautiful old building, which may not be designed perfectly for large venues for conferences, but it's worthwhile visiting from the historical perspective. And the following year, we had some courses at the Royal Society of Medicine. You may see some familiar faces up here, so if you look closely. And this is how we try to make education fun, because you want to actually engage people. And this was about whether you saw something that looked benign initially, clinically, but actually with dermoscopy, you're able to see these subtle features to actually confidently diagnose melanoma in situ in these cases. From 2005, we also tried to actually move the education not only into from secondary care or tertiary care, but to primary care. So we started working with the Primary Care Dermatology Society, and we started going across the country, not only to hospital departments, but also with colleagues delivering education in Scotland and across to Ireland, and also well across the UK. So I'd like to thank some of those colleagues who are in the room who've been helping with that education over the last 20 years. So we don't want to leave the surgeons out, because they also, depending on where you live, you may have a cancer pathway that actually will be delivered by plastic surgeons. So we want to get them involved in diagnosis. And with Oliver Cassell, a great friend and colleague in Oxford, we started running an international course for plastic surgeons. And we get plastic surgeons from not only across the country, but globally, coming to Oxford to spend the day learning about dermoscopy. And what was quite fun is the fact that we now have evidence that you can train a plastic surgeon. And talk about training. So this was also, I'd like to thank Giles Dunhill, in the early 2000s, trying to get dermoscopy into the UK dermatology curriculum. And it took a while, but we got it in there. And this is the updated curriculum from 2021. But you've got those measuring points, those 9 points of reference. How do you actually sign off a trainee on competence? But this is what I think is quite interesting in that document from 2021, is avoiding unnecessary procedures. So perhaps every patient who walks in and walks out without a biopsy, you sign them off. They did great, because they haven't exercised 200 seb-Ks. But how do you qualify, quantify, and actually measure that outcome? What is the standard? So we looked at our data in Oxford, and I'd like to thank Ben for his work with this as well. We introduced dermoscopy in about 2004, and then we looked at the practice in 2006, and the Skin Cancer Service was pretty good back then. But the actual pathology, also the theatres, were also having cases pulled in from all sorts of clinics. So there wasn't a selective diagnostic pinch point of dermoscopy, which was then, of who's allowed to actually be operated upon. So we changed the pathway. So we changed the pathway, and then we re-looked again at the cases 5 years later. So now you had a diagnostic dermoscopic pinch point. A case couldn't be operated on unless somebody who's experienced in dermoscopy had to look at it to say whether it was nice or nasty. And these are the results. So we had a pretty good benign to malignant, or number needed to treat, in 2006, and changing the pathway to make it more efficient, we had better outcomes as well. So benign to malignant 1.7, and this is an unselected NHS tumour service, which you will all be delivering across the country. And also we have our invasive to in situ ratio, the melanoma to melanoma in situ of 1.7. So how good is that? So that's the challenge, is we put our flag up, we said this is our data, how's yours? And there's a lot of data missing, but thankfully last year, a couple of years ago, Petty from Duke University did a meta-analysis. So looked at papers that have been published where there is data available to extract to find out from these large cancer centers how good you are at diagnosing melanoma. And they use the marker number needed to treat, which is always your benign to malignant plus 1. And here's the data. So going from the left-hand side, the blue, which is primary care. Then if you have a dermatology service, there are your results in red. And then if you have a specialist dermatology service, so dermoscopy particularly, you're in green. And through across the other side with a bit more primary care with dermatology experience, and again, dermatologists with some other experience as well. So before we actually introduced that diagnostic pinch point, by using dermoscopy for a few years, we were already pretty good. And what's quite nice is you can now say we are practicing in comparable to our peers. There's some very talented and very experienced dermatologists on that paper there with Argenziano, Carly, Menzies, Kittler, and also Holger Hensler from Germany as well. So we can say that our practice is similar. So there it is. That's what a benign to malignant ratio of 1.7 looks like. It's lonely, isn't it? It doesn't look, I mean, how helpful is that as a marker? So let's put another marker in as well. So this is from two very experienced New York dermatologists, so Alan Halpern and Ash Magoob, who have been using dermoscopy for decades. And this is a combined data set from them for 10 years, 1998 to 2008. And we can see that there's a difference. The question is, who's better? Is Oxford data better than New York data? And that's on number needed to treat. It's missing something, isn't it? There's no depth. So a number needed to treat doesn't really give you a lot. What you want to try and find is a lot more information. And if you use your malignant invasive disease to in situ ratio, you've now got a quality outcome measure. So you can actually measure what your service is actually delivering, not just how many procedures you're doing, because you want to know, are you able to diagnose melanoma, and also the spectrum of melanoma. And if this was a comparable set of data between two departments, you could now actually have a direct cost comparison between two departments. But also, you could also make a decision for your department, what's more important? And for the patients, is it picking up earlier melanoma by the details from America, or would it be you don't want to do too many procedures at the risk, at the tension then of actually developing or picking up thicker melanomas, but you're not doing more procedures. So you have to try and work out which is better. Or actually, if you're just on this page, you're good enough. So how can you get better? Well, if you integrate digital dermoscopy into your practice, you can improve things. So there's a number of terms here. So you either got the sequential digital dermoscopic imaging, SDDI, which is an overarching term. And then you can either do short-term or long-term digital dermoscopy. Long-term only if you've got lentiginous lesions. They are slow to change. So there's no point doing that very quickly. You need to give a long lead for that. But what about short-term dermoscopic monitoring? And it's great to hear and listen to Carolyn's talk about image capture in primary care, in the community, and how that can be coming through into secondary care. So this is digital dermoscopy in a nutshell, and how it will impact your clinical practice. So if you have one of these devices, or these machines, or just a camera and a device, and you capture an image at baseline. So this patient was referred in, index lesion, changing mole on the back. We've all had those referrals. And you have a look and you think, well, do you know what? You look at all of them with dermoscopy and they all look pretty straightforward. And the one on the top left of those four images, you might think, well, it's a little bit asymmetrical, but it's not enough to really think we need to do anything. Let's just pause and re-image. So you take a further image 3 months later, and then you can prove that it's not changing. There's no significant change here dermoscopically. Therefore, we can actually leave this and not do surgery. There's another example of a non-changing mole as an example. So we can reduce unnecessary excisions. But we can also find melanoma early. Because if you look at everything and you now find a very small lesion that looks asymmetrical with the focus that does look more complicated, you can track that. So this is digital dermoscopy, twofold. Reduce unnecessary excisions and find things that are early. So this is John Powley's data from that study from Gothenburg. And what you can now see, things have improved. you've got a reduction in your benign to malignant ratio, and equally, you're now actually reducing your invasive to in situ ratio as well. So you're finding earlier disease in melanoma, but you're not actually taking any further numbers of biopsies to do so. So that's actually an improvement in both cost and outcomes. Now, some of you may know I work independently now for the last few years, and so what's important for independent providers is to know what we do. We don't know what doesn't happen. You can only measure what you do. And this is very straightforward data. This is just your surgical outcomes of melanocytic lesions per annum, and then you work out of those how many were melanoma, and of those which are melanoma, how many were in situ and how many were invasive. And that gives you all this data. So that shows your clinical activity. And I don't want to be up here or down there. I just want to be practicing similar to my peers. I want to be in the same group as them, in the same room. So that's my data, which shows it's pretty similar to John's from Gothenburg. And this is Alex, Alex Chamberlain, a very experienced dermatologist from Melbourne, who was running the Melanoma Institute, the Victorian Melanoma Department, Institute in Melbourne. So I also practice very similarly to Alex, and we are poles apart geographically, but how we practice medicine and practice diagnostics on melanoma is very similar. And I'm quite happy with that because I think you can now show we've got comparable data. If you've got people who are using digital dermoscopy into their clinical practice, it can be similar. So it's not about trying to be the best. I just want to be comparable to guys who I think are peers. So you want to have clustering of your data. But you need to know your data. It's very simple data to find. It will take you half an hour, an hour. But you can find your data and work out where you are. And what you want to be is to the left of that line, I think. Because if you're to the left of the 1.0 for invasive to in situ line, that is telling you that you're good at diagnosing early melanoma. That shows that you're picking up more in situ disease than you are finding invasive disease. And that's quite good, isn't it? That's a nice quality outcome. Because you can then brand yourself as somebody, come and see me, I can find early melanoma better than somebody who perhaps may have an invasive to in situ ratio further down the line. So that's a very important area to be. You want to be in that zone if you can. And the good thing is, 10 years ago, Rebecca and the team in Oxford and Scotland, we had a look at the data across the UK. So 10 years ago, 98% of dermatologists were now using dermoscopy. So there's no reason why people can't be using dermoscopy for this. Sustainability. It costs money to open a theatre and to operate. There's great work by the Dermatology Sustainability UK group that's been presented and awarded and rewarded at this meeting. But we have to think it costs money to open the surgical pack and operate. So you want to make a good decision at that time. Are you going to operate or not? Not just because of the patient, not just because of the cost, but actually there's an environmental cost. If you are just operating and operating, all those consumables have to go somewhere. So we go back to this chart here. You want to head up towards that top corner, and I just want to be comparable data, whether that's departmental or whether that's individual data. So maybe we can think of this zone as a diagnostic zone you want to habitat, where you actually, why don't we call this diagnostic sustainability? Nice and catchy. Where we can actually prove that not only are we good at diagnosing melanoma for the patient, but at a lower cost and a reduced environmental impact. That shows we're cost effective, and we're good as a good green at a target we should aim for. But you've got to know your data to know where you are. Okay, and if you start operating and using dermoscopy, you will find that your clinical practice also changes over the years. And so basal cell carcinomas, we can very accurately and confidently describe the different histopathological subtypes on dermoscopy. Superficial nodular, micronodular, infiltrative, as we can see here. And then you can change your surgical outcome. There may be some surgeons here. But if you're finding things that are very small, and you know it's got a very straightforward histopathological growth pattern, you can do a very simple procedure. You don't have to be complicated. But equally, if you find something that's a little bit more complicated histopathologically, you have to bear that in mind for any surgical outcome or procedure that you're planning to undertake. But also the size of BCCs have changed. And this is paper from Ishizaki from Japan. And they showed that over this time in the late 90s to the 2000s, when they started introducing dermoscopy, the case mix of patients changed. So we have a very typical basal cell carcinoma here, call this the pre-dermoscopy era. And now we have a very typical BCC in the dermoscopy era. Everybody happy? Everyone confident? The only way you find this, typically, is by looking at high-risk sites with dermoscopy. Nasal alar, they're out there. BCCs are on our patients. There's a great site to go looking for. There it is, marked, and here it is. So that's where you want to be. It influences your management. And if we know we have the data to prove that we're good at diagnosing in situ disease, so we know we're good at diagnosing in situ disease by our data, we can change how we manage our patients. And this is, again, paper from Sweden. And what they thought is they've got good concordance of diagnosing in situ disease, so why do you have to do a wide excision? Why don't you just do a one-off 5mm excision, and you know that you're going to pick up in situ disease and save people coming back to theatre for a later date, so less resources. And again, something similar, was very pleased to see the data from Leeds that was presented earlier this week, also thinking about how we manage in situ disease on non-head and neck sites. And then AI. Variables, there's so many variables out there. The device, whether you have pigmentation enhancement or not, whether it's polarized, non-polarized, and whether you're using a contact device or another. And the question is, how is this going to be impacted with regards to capturing data sets for AI in the future? Great work from Colin with regards to the DICOM standardization. That's going to be brilliant work to help. Because most AI-based technologies are using clinical pictures. They're not using dermoscopic pictures. And because dermoscopic pictures are difficult to obtain, not every member of the public will have a dermoscopic device. But hopefully they will someday. And then the question is, what do you put into the data set? Do you put in a very thin melanoma on the top, in situ disease, or are you just putting in your barn door thick melanomas? And these are the variables that you will see of choices that you have if you're putting a dermoscopic image in. Whichever device you want to use, whether you're using polarized or non-polarized, whether you're having a focal zone. There's another question on this week. Can the whole lesion fit onto an actual dermoscopic image or not? But we can't forget the clinical image also as well, because clinically you can see the actual outline of that melanoma extends far beyond what was passed along on the dermoscopic image. Dermoscopy diagnosis, it's not straightforward. It can be challenging. And if you're going to actually use dermoscopy, you've got to then find, it's not a linear thread. You don't just go through history, examination, anatomical site consideration, dermoscopy, diagnosis. It's not. It's a little bit more complex than that. You tend to go back and forth. You think it is, you go back and have another look, maybe ask another question, and you keep doing that until you actually have this big interwoven thread, which is what diagnosis is. And that could be, as we're in Scotland, a diagnostic tartan, where we combine all those elements together to actually give us a diagnosis. And if we use dermoscopy, our clinical diagnosis gets better. So you can see this obvious melanoma. You know it's an obvious melanoma clinically. But this melanoma here, we can see the melanoma and dermoscopic features of tiered globules at the peripheral margin. But now we know they're there, you can go to the clinical picture and you can see them as well. So your clinical decision-making, your clinical judgment will get better, and your clinical diagnosis even without dermoscopy. So again, the question is, what's going to go into the AI? Is it going to be dermoscopy clinically, or is it going to be the dermoscopic image? To close, I would just like to thank these two guys, John Powley, Alex Chamberlain, who kept me sane during lockdown with a project of trying to write the updated book. So there's a bit of a plug there. And also to get involved with the International Dermoscopy Society if you can, because it's a great organisation, and every dermoscopy meeting you go to will be fun. And everyone likes sharing the interesting cases that they've got from their back catalogue. And you're never too young to start to use dermoscopy. Thank you.
Thank you very much, Jonathan. Fantastic talk, as always. I think we've got time for one or two questions, potentially. If there's nothing, I'll ask. Salim?
Thanks, that was a great presentation. Do you have any comments about provision of dermoscopy to the pathologist? We had a presentation right at the beginning of the meeting, how it seems to actually influence the diagnosis.
I think so. It's good to see you, Salim. Thank you for the question. I think our pathologists have changed a lot from their practice based on what we give them. And so historically, at the start in the early, late 90s, they would often have a very binary outcome of melanocytic nevi, benign or nasty. Now, their whole case mix is at that diagnostic threshold of, is it in situ, is it severely dysplastic, can't exclude evolving in situ. So I think the pathology case mix is now really concertinaed in, and they're getting much more challenging cases. And therefore, I think it's important to actually work with your pathologist. We're only as good as the reports and based on the information we give our pathologists. So do invest time with your pathologist, because even if that's submitting a dermoscopic image with an area outlined for the macro cut-up, that can be quite helpful as well.
Thank you very much, Jonathan. Don't leave. I'm coming to you, so hang on there a second. So the next speaker gives me great pleasure to introduce my colleague in Cardiff, John Ingram. As you all know, he's the editor-in-chief of the British Journal of Dermatology. And congratulations, John, with the rise in the impact factor. That's fantastic news. You're a consultant dermatologist in the Welsh Institute of Dermatology, and it's a great pleasure to hear about your experience in hidradenitis suppurativa and really all the work that you've done in the last few years. So thank you, John.
Thank you, Mabs, and it's a real pleasure to have the chance to present to you, and my thanks to the BAD for the invitation. So hidradenitis suppurativa, HS, running to catch up. Here are my disclosures. And you know, HS is a life-changing and a life-shortening condition as well, and of course is a clinical diagnosis, and yet remains a challenge, I think, to us all in terms of that diagnostic delay and in terms of management. So my role today is to update you on new happenings in HS therapy, and also crucially what we're doing in HS research, a global mission really to improve the care of our patients. And so I'll talk you through epidemiology first up. I want to cover the historic global collaboration outcome measures to define treatment success or failure in HS, which is a real challenge for us still. So I'll show you the work the Historic has been doing there. I want to touch on medical therapy and on surgical therapy, and crucially the integration between those two modalities in a scarring condition that does require that integration. I want to give you a bit of an update around Theseus, the first publicly funded UK trial for HS, where we've been comparing 5 different interventions, both medical and surgical interventions in 10 sites across the UK. And then closing really with some tips around screening and holistic MDT management for our patients. And throughout my talk, I want to weave in the current challenges that I think we all face in managing our patient group. So back to the title, Running to Catch Up. I think we make comparisons sometimes with psoriasis, and the key one here is the diagnostic delay that we face in HS. The average is just over 7 years, and there was a very nice paper that made a direct comparison to the equivalent delay in psoriasis, which was 1.5 years. And that 5.5 years of delay, of course, can produce really extreme impact on our patients who are generating progressive scarring and impact on their cumulative life course over time. And when we compare with psoriasis, the situation right now is we have one licensed therapy for HS, as you know, adalimumab. And this really, you can compare with psoriasis probably back in 2004, where we just had etanercept, and we're probably running around just under 20 years behind there. But there is progress, and I'll come back to that in a moment. So what is the true prevalence of HS in the UK and globally? Well, we start perhaps with the US data. That gives us very low prevalence figures of 0.1%. That's using insurance-based data. And we know that a lot of people with HS really fall out of the insurance coverage. In the UK, we've shown that the prevalence is probably around 1%. And in continental Europe, there have been self-reported questionnaires that have shown a prevalence of perhaps nearer 2%. And if one examines patients in high-risk groups, that can be as high as 4%. So in the UK, we did a study using the primary care data set in CPRD, and that allowed us to look at 4 million primary care patients, and we found that using the read codes for HS and validated cases with at least 5 flexural boils, that produces a prevalence of 0.77%. But when you add in patients who haven't got a diagnostic read code for HS, but who have in the electronic record 1 to 4 flexural skin boils, so they're very likely to have HS, that prevalence goes up to nearly 1.2%. And the findings from the study fitted with our understanding of the epidemiology that there's a 3-to-1 female to male ratio. It affects young adults, particularly young women. And so in that sort of a category in the 3rd and 4th decades of life in women, the prevalence we found was 1.5%. So it's a pretty common condition. And I hope that we can sort of move the whole concept of HS into perhaps acne, psoriasis, eczema, and HS. They're the big 4 conditions that we face in inflammatory dermatology. And of course, we have these environmental associations, and they fit together with the genetic profile of HS. There's a very strong inheritance pattern. At least 40% of our patients will have a first-degree relative with HS. They may not even know it themselves because families don't necessarily share this, but it's certainly been found. There's a single gene defect in the Han Chinese population in terms of gamma secretase, a particular protein in keratinocyte differentiation. We don't find it in our HS cohorts in Europe and in North America. There are strong disease associations, as I'm sure you're aware, and some of the classical ones are things like Crohn's disease and seronegative arthritis, but also psoriasis as well. But really thinking about where we can perhaps make the most difference in terms of impact of HS, important not to forget the links with metabolic syndrome, with cardiovascular disease, and with mental health problems. And they can produce the mortality that we see in HS in terms of cardiac disease and completed suicide, quite a high increased risk. And don't forget also the risk of cutaneous SCC for patients really with long-standing perianal disease in particular. So do biopsy atypical lesions in that particular patient group if you have a suspicion. So that's a bit about the background there of the epidemiology. But then what are we doing right now in terms of research to really help us design better trials to tackle this challenging problem? And Historic was a group that I helped to found a few years ago now. And the important element for me is that it has a 50% patient representation. So we've had several face-to-face meetings with patients and clinicians in North America and Europe, really trying to work through what should we be measuring in HS. And patients are an important component of that because clinicians, we're not great at counting lesions in HS, and I'm sure you found the same thing, that it's difficult to distinguish between nodules and abscesses. How do we count tunnels? And we are really guessing how many there are, how many branches there are without ultrasound, for example. So here is a study we did. We all went over to Denmark. Gregor Gemmet hosted us to examine 24 patients one weekend, the 12 of us from 12 different countries. And we found that we were pretty good at defining the early staging in our patients, as you might expect, mild, moderate, and severe. But then when one was looking at the physician's global assessment and moving into other scores, such as a high score that, of course, we use for the NICE approval for adalimumab, the ratings went way lower. And a newer measure there, the IHS4, we had fair agreement on. So this is, we're not perfect as clinicians, and I think it's really important to be mindful of that. And so Historic said, well, what really matters to patients and to the people caring for them? And we came up with 6 domains, the what to measure in HS clinical trials. And we have the physical signs domain there with the lesion counts, but we have 5 other domains, 4 of which have a strong patient-reported component. So pain is up there at the top. It's always the most impactful symptom. We have HS-specific quality of life, global assessment, which has a patient and a physician component, and then beginning to sort of really appreciate that what we're all about here is trying to slow disease progression, to prevent scarring, and to intervene earlier in that process. So for medical interventions, one can look at flare frequency. There's a challenge in how do we define a flare. That's a whole piece of work in its own right. That's ongoing. And then the other element is surgical interventions and time to recurrence. We also found that our patients were very strong supporters of the symptoms of drainage and fatigue as being key elements, and they were moved into the core set as our 6th domain. And then the next step is to find the instruments that will allow us to measure those domains. And so there's been work going on in each of those 6 areas, one of which is HISQUAL, the HS-specific quality of life instrument. This has 17 items arranged in 3 subdomains. It's freely available for you to use in your clinics. Just drop me an email and I'll send it across to you. One of the elements to highlight is that there's a separate category for unable to do an activity because of HS. And this avoids the issue that many of our patients might otherwise mark not relevant to an activity because they couldn't even conceive of being able to do it. And so we give that the top score in our instruments to ensure that that impact is captured. So you've probably seen the 2018 guidelines that we produced through the BAD with Firouz Mustafa's tremendous help. Beyond oral tetracyclines, back in 2018, we were very much then thinking about clindamycin and rifampicin as the go-to treatment for suppurative disease. And I still think that is our go-to next option. It's a very clever combination. You've got the enzyme induction from rifampicin, which is reducing the effective circulating concentration of clindamycin down to a level where we don't see C. diff diarrhea, but it does provide sufficient levels to prevent resistance to rifampicin monotherapy in the staphylococcal bacteria that may be part of the issue here. So beyond that, there's acitretin for males and non-fertile females, but of course that's a relatively small proportion of our total patient group, most of whom aren't suitable for acitretin. I do find that acitretin can be helpful in cystic phenotypes of disease. I'm using less dapsone now. I don't know about yourselves, but I find it can be helpful in mild to moderate disease, but I don't have many treatment successes beyond that. And during the pandemic, perhaps monitoring was also quite intensive as well. So beyond that, we have adalimumab, of course, and we have the nice guidance around that. Beyond that is infliximab as the second-line biologic. But here we have an issue in that access to infliximab, certainly in England, has diminished over time because now it's in the guidelines. Individual patient funding requests are not so easy to have approved. And so, in fact, without NICE approval for infliximab because of a lack of robust evidence, in fact, access has diminished. So we really are now looking at sort of adalimumab as being our sole biologic that's straightforward to access. There still remains the issue of how also we integrate that with surgery, and I'll come back to that in a second. So, of course, guidelines have a cut-off point even before they're published. The systematic review has to conclude so that we can analyze the results. And beyond that, we're already starting to use other treatments. And in women, oral spironolactone has become quite a useful option. We use it for its anti-androgen properties. It's well tolerated. Perhaps breast tenderness is the main adverse effect. It comes in a single 100 milligram tablet, which I tend to find that's a decent dose to use. I always check baseline renal function and avoid, of course, other potassium elevating therapies. So, I think that's coming through now as quite a useful co-therapy. A few patients we're managing on spironolactone monotherapy, but often it's in combination. Metformin is similar in a way. Maybe it should almost be in the water for our patients, in terms of its multiple benefits in HS. It has the anti-androgen property that we're mainly using it for, but some handy extra elements, in terms of course, treatment of type 2 diabetes in our patient group. Metabolic syndrome has a very high prevalence, and also polycystic ovary syndrome. It can have a role there as well. It's safe in pregnancy. You may get a little bit of weight loss, although I do underplay that because often it's not noticeable. It can cause some gastric upset, but it's typically very well tolerated. And I always check baseline renal function and keep an eye on hemoglobin because there is a possibility that could drop. I use a modified release preparation twice daily with food just to avoid any theoretical risk of lowering blood sugars, but in practice that's not really been found. So how then are we managing our treatment with adalimumab? One issue we have, of course, is that the PIONEER studies showed that there was a 50% reduction in inflammatory lesions in 50% of our patient population, which is not really good enough in a lot of our patient group. And so we may have primary failure of adalimumab. We may also have secondary failure if the response to adalimumab is lost over time, and I quite often see that. So what do you do in that situation if you can't access infliximab, you've still got ongoing inflammatory disease? Well, the answer has been to add back in that ladder of oral therapies that we were using prior to biologics. In the PIONEER 2 study, a lot of patients were already taking oral tetracyclines, very straightforward to restart those. And then go up in terms of CLIND and RIF, and adding in the anti-androgen therapies I've just mentioned. And essentially what we're doing here is, trying to maintain or recapture a response to adalimumab when we only have one licensed biologic. And beyond that, of course, is individual funding requests and off-license use. So that has its own challenges. How do we manage very severe HS? Well, Ruth Lamb gave us a really excellent talk on how to bring together different elements. We can add in antibiotics, both oral and intravenous, for patients to gain control in severe acute disease. The biologic may be a very nice way of controlling inflammation to expose residual scarring that allows us to just target those areas once the inflammation is controlled. IV antibiotics can be provided by a home IV service, so we're using that from time to time. I think it's useful to link up with those services. And then for a handful of patients, systemic steroids are being used, particularly in the USA. I've used them occasionally in my own practice as a bridge with a plan to go beyond, what to do next. But our patients are really suffering, and so it's a tricky one. And then we have this potential set of biologics that are tantalizingly close, but not yet licensed. And we're yet to see the phase 3 trials read out their data, but they're relatively close now in some cases. And here's the pipeline. Phase 3 there on the right, you can see the anti-IL-17 biologics are about to finish their phase 3 work, and we should have results in the next 6 to 12 months. There's also the anti-IL-23 biologics. The JAK inhibitors are in phase 2 now, and we have anti-C5a complement inhibitors that are coming through. Interestingly, they were using HiSCR as their endpoint, and the first of those trials gave a negative result on HiSCR. But HiSCR doesn't allow us to count draining skin tunnels, an important element for our patients. And when they were analysed separately, there was definite benefit, and the FDA has reflected on that and responded, and is now willing to allow a measure of draining skin tunnels to be taken forward in terms of measuring efficacy. So there's certainly potential. And how do we combine surgery with biologics? Well, the aim here is to stabilize the inflammatory component to allow surgery to be done more easily. And Falk Bacara and colleagues produced their SHARPS trial report last year. This was a group of patients who all needed wide excisional surgery, and they were randomized to receiving either adalimumab or dummy injections for 12 weeks prior to surgery, and then they were treated during and for 12 weeks afterwards. And there was no increase in complications in the adalimumab treated group, and when we measured overall HS activity, it was improved in the actively treated arm. And you might expect that really because there's plenty of HS that may be active in other locations other than where surgery was performed, and also it's providing and preventing disease relapse in those surgically treated areas. So, a different paradigm compared to, say, psoriasis, but I stress this is for HS skin surgery, and safety would dictate that for internal surgery, adalimumab will be paused as usual. But trying to get good inflammatory skin control. So deroofing is an option for more targeted surgical therapy, and Theseus, the trial I'll just mention in a second, was able to introduce that into 10 centres in the UK. In this local anaesthetic procedure, the key element is to probe skin tunnels with a blunt probe, as you can see here. That can lift up the roof of the tunnel, and then a loop diathermy, or just scissors and a scalpel blade, can then be used to remove the roof of the tunnel. It exposes the gelatinous inflammatory material beneath, which can be scraped away and allow secondary intention healing to occur as a tissue-sparing procedure. Our deroofing video we produced for Theseus is coming close now to 1 million views through the trial website. So do have a look if you're interested in taking this technique forward. It's really quite straightforward. The Theseus team, you can see us here pre-pandemic in our kickoff meeting with patients embedded in our trial team. We were able to have 10 sites across the UK, England, Wales and Scotland, recruiting a mixture of dermatology and plastic surgery sites, and also then MDT-led sites to allow us to recruit. And this really is an example of the challenge of trying to do a clinical trial during a pandemic. You can see that the red line is where we were looking to start our recruitment, but the pandemic first wave hit about a month later. So we then produced our blue line of where we would like to restart the trial beyond the first wave, and the orange line is what we actually achieved. And you can see that if you can make out here the peaks of the 2 waves of the pandemic, we had a paused start because of the first wave. We then recruited quite strongly, about 20 participants a month, and then the second wave caused the line to flatten, and we got there in the time beyond the second wave last spring. So Theseus recruited from secondary care. We certainly found that our 150 participants reflected the kind of patients I think we all see in our dermatology clinics. Average age was 4th decade of life, women, more females than males in the sort of standard ratio, a spread of racial spectrum across our recruitment cohorts with a range of skin color. Nearly half were current smokers, and nearly 90% had a high or very high BMI. And this was a non-randomized trial. It was really a challenge from the HTA, our funder, to say, could we mobilize a HS research community to deliver clinical trials to come? So as an unrandomized trial, we offered 5 different interventions, and it was a choice between the patients and their clinician, as we would do in clinic every day, to which of these 5 they would opt for. And so that included doxycycline, Clinton Riff, laser hair removal treatment, the de-roofing I've shown you, and conventional surgery. And our primary outcome was collected on day 1, which was for the clinician to say regarding eligibility, what would be suitable, and for the patient to express their willingness or otherwise to take that option. And you can see that laser was our top scored option, followed by de-roofing, and then surgery and the antibiotic arms. So really showing that laser and de-roofing as these sort of novel therapies were certainly strongly supported by clinicians and our participants. So I want to just sort of close by mentioning that holistic care for people with HS is so important, and I've already sort of stressed the issue around screening for cardiovascular risk and also for mental health problems. I think that's a great chance for us to link with our primary care colleagues who are experts at this, and we're really just learning. Also important to offer lifestyle modification if it's relevant. We still see plenty of our patients who are not overweight, they're non-smokers, they may have a family history, but still they're having severe progressive disease. And I think we're all conscious that we need help in the management of our challenging patients. And I feel that dermatologists, we have that central role of coordinating the MDT, and it's about bringing in the expertise that we need, be that our biologic specialist nurse colleagues who are now reskilling from psoriasis and now providing care for our people with HS, linking with surgeons, that may be plastic surgeons depending on your local network. In Cardiff, I link with a breast surgeon for above-the-waist surgery and for a colorectal surgeon for below-the-waist procedures. Wound healing, of course, is vital. We have to really ensure that patients go into these procedures with careful preoperative counselling, given prolonged healing times. And then a whole set of other expertise, including vulval, urology expertise, lifestyle, of course, I've mentioned. Linking with your microbiologist is key to gain access to these restricted antibiotics, particularly if you need to use IV options. Clinical psychology we also, I think, would like more of, but HS, my goodness, is that a deserving focus for if you can find psychology for your inflammatory dermatoses. And finally, many of our patients live in chronic pain, and so we have to be mindful of that. We're very good at managing pruritus, but I think we need to look to chronic pain clinics to support us in that element as well. So I'll leave you there, and I'm very happy to take questions.
Thank you, John. It's a very comprehensive review and also telling us about new developments. I think in the interest of time, we will move on. So thank you very much. John.
So for the next speaker, I'm delighted to introduce our BAD President, Dr. Mabs Chowdhury.
Mabs is a consultant dermatology at the Welsh Institute of Dermatology in Cardiff and is honorary senior lecturer at Cardiff University. He's clinical lead for e-learning for health and past chair of the SCE exam board. He's co-editor of the Dermatology Training Essentials and also is one of the associate editors of the next 10th edition of Rook Book. So congratulations, Mabs, and I've introduced Mabs Chowdhury. Thank you.
Thank you very much, Tanya. It's very kind of you with those kind words. I've got one declaration. I have no slides, so that's what the lady was checking earlier, because she was getting a little bit panicky. It's really great to be here and seeing you all face to face. It's a real privilege to be standing here as your BAD president. This annual meeting has been a complete and utter success, and it's really due to the whole conferencing team and Pew Banerjee particularly, who's set up a fantastic program, and I think we should give her a round of applause. Glasgow's been a fantastic venue, and I think we should actually thank our local Scottish colleagues and all the Scottish speakers from Edinburgh, Dundee, Glasgow, of course, and all the colleagues that are here. Thank you. So it's a true honor and pleasure to be standing here as your president, deliver this address. It's been a long time coming. The elections, believe it or not, are sort of January, 18 months before take up post. This is not something you ever imagined you'd be doing standing here. Really, at my first ever BAD meeting, I can remember Adrian I think it was 96, 97, delivering his president's address. And it was a fantastic address. And when you're attending there as a junior registrar, you do realize it's a big, big job to do. And you still realize that now, of course. So just imagine a young boy born in Manchester to highly educated parents who just moved to the UK in the 60s. They've both come on education scholarships to various diplomas, PhDs, actually in Salford. And then imagine they uproot and move a 8-year-old boy to actually the Middle East, where English medium schooling is in fact non-existent, and the whole education system is pretty appalling. But you still manage to get some O-levels and come back to this country 6,000 miles away on your own and do A-levels, get into university, and in fact get into medical school at the age of 17. And miss 2 years of school between the age of 10, where there was no schooling, as I've just said. So that's my story to start with. And by the way, missing 2 years of school at that age was actually fantastic. It was very, very enjoyable. So I'm a true believer that anybody can achieve anything with the right belief and right support, albeit from family, friends, and close colleagues. But essentially, if we put our mind to it, whatever creed, color, background, ethnicity, gender, origin, we can achieve everything with equal opportunities and hard work. Now, of course, the equal opportunities need to present them to you, and when they do, I believe you need to be ready to take up those opportunities and really be first in the queue to put yourself forward. It's a gift for life, really, and embrace those opportunities to perform to your utmost maximum of your abilities, and then to work tirelessly and honestly with self-respect and dedication to deliver at a high level of excellence. And without bias and prejudice, of course, to others, and I firmly believe we should always be considerate and polite to everyone, and on time for everything. And my trainees will actually tell you that is true. It's a bit of a bugbear of mine. So having worked in London, the Midlands, including Birmingham, Leicester, in the north, in Newcastle, Sunderland, Middlesbrough, Manchester, now in Wales, in Swansea, Bridgend, Newport and Cardiff, and I also have worked and observed practices in the Middle East and the USA. I believe I both have a very broad life experience and a very broad and wide clinical experience and global outlook in medicine and dermatology. This has certainly stood me in great stead and in my career, and helped me in all the varied leadership positions that I've undertaken.